Yes, Dr. Sam.
Great. So, who are we missing at the moment? We have Nabi. Right. So we have Prashani. Who else? We're waiting for Asiri, and we're waiting for Shimon. Right. So we'll give a couple of more minutes, and then we'll start. Let me start my as well. So, how was your evening yesterday? Did you have any afterthoughts after listening to the content yesterday?
Dr. Sam, I have an update to share. I just called Dr. Shuman. He is not feeling well. So he said he may not be able to attend today.
Right. Sure, Nabi. Please ask him from our side. I hope he feels better soon.
Okay,
yeah.
Sure. Okay.
For me, the thoughts came into my mind is especially about while reading the article, you have pointed 3 points that is it new, is it true, and if so, what? So this is really nice. There are so many new topic for me, but this one is really striking me. And I was reading one article that manuscript that I had to review, and I was thinking about these three question in my mind, and I'm practicing it.
Yeah, no, that's great. That's great because this has helped me till date. So yeah, that's a great contribution that Professor Francis Creed made. Yeah, that's good. That's good. So I think we can start if Asiri joins in. Sure.
Dr. Siham, Dr. Asiri sent me a message saying she is not well, so won't be able to join today.
Oh, okay. No worries. Please ask her from our side, and I hope she gets well soon. Right. So let's start. First, I think we have a short recap for today, and then we will. There was a topic left yesterday. I will just glide through those slides and get into more understanding of different types of potential biases. We did talk about it yesterday. Then Professor Dwallo will talk about the power size calculations. I'll then take up the measurements once he's done, an overview about measurements and how do you adapt them, what's validity, reliability. I'm sure you have a pretty good knowledge about this. It's always good to have a little bit of overview given again. And then we will sort of, before we break at 12:30 UK time, we'll start thinking about the kinds of tools and instruments that you're all going to be using in your PhD studies. Then after the break, Dr. Ahmed Waqas will take up the analysis bit, which will then go into day 3 as well. So if I were to sort of ask you, what things did we cover yesterday? Let's all try and pitch in things that we covered. We did talk about design. So in about 10 or 15 minutes, let's just recall what we covered. So anything that comes to your mind, please start sharing.
So under study design types, we looked at descriptive study designs, analytical ones,
Yeah.
and under that descriptive studies, we talked about case report, case series, and also we talked about observational and experimental studies.
Yeah.
Yeah, so we talked about cross-sectional, case control, RCT and CRCT, so more on that, and then internal and external validity. So conceptual clarity on those issues.
Yeah, great. Good. Anybody would like to add to the things that we covered or elaborate any point that Prasansa just mentioned?
Dr. Siam, I have a question in mind just to
Sure.
be confirmed about the complex intervention.
Mhm.
The paper you showed from the Pakistan one, in the intervention side, they have 3 arms. So I understand it's a complex intervention, but when
Yeah.
you deliver intervention in 2 phases, for example, in Sri Lanka case, Prasansa is first giving training to the delivery agents, and then the delivery agents will deliver the intervention to the
Yeah.
recipient. So is it also a complex intervention in 2 phases?
Yeah, I understand what your question is. And before I jump in, anybody would like to perhaps respond to Nabi's question? Prasansa, Pragya, Nida, Prashani, any thoughts about the complex interventions? We did cover that.
We did talk about like different elements of complex interventions. One that I remember is like complex interventions has like multiple issues that it looks at. So maybe it tests one area, but also tests the other as well, other element or variable. Maybe that can also be counted as complex intervention. And also when an intervention is adopted to different setting, and there might be certain issues that come into play. So I guess considering those, my study might also fall under complex intervention.
Absolutely. Absolutely. Yeah. So Nabi, just to quickly remind you that complex intervention, there's no sharp boundary or distinction of what is a simple or what's a complex intervention. Generally, when there are multiple components within an intervention, if they, like I gave you the example, like Nabi just pointed out that in Pakistan, they were using multiple components within an intervention and they were testing them within multiple arms. So they were testing nutrition, they were testing stimulation, child bonding, they were testing regular routine visits as well. And then the fourth arm was a combination of parental bonding and stimulation, as well as responsive feeding and micronutrients. So these interventions, they're all complex in terms of their content. Now, the complexity of being a complex intervention also comes from the context in which you're giving, the partners that you're working with. Probably, like Nabi pointed out, that in Nepal, people, specialists will train non-specialists, which are community volunteer females. They will then deliver the intervention to within households, to face-to-face and house visits. So the minute that you start thinking of multiple stakeholders, multiple people to train, multiple moving parts, when I say moving parts, I'm talking about the implementation. So more stakeholders, the more complex, versus the original Thinking Healthy program, where a psychiatrist directly trained and supervised the community health workers, was a simpler version of training and supervision, which is always part of the complex intervention. So I hope that answers your question, Nabi.
Yeah, it is. Thank you so much.
Right. In terms of our content that we covered yesterday, we did touch upon in quite a bit of detail that we, in public health, in global health, in epidemiology, even in social sciences, even in allied health disciplines, we're always interested in if our intervention is causing or is delivering the desired effect. So all these study designs at the heart are trying to understand if they actually make a change. So we try and evaluate them. Even in observational studies, where we're trying to just observe and understand what is causing what. Yeah. So is depression, is poverty a risk factor for depression? Is maternal depression, the odds of having maternal depression higher in women with more than 3 children? So even if they are observational studies, we are always trying to link 2-3 variables to understand the cause and effect, right? So if there is exposure, is this linked with the outcome or not? So please keep in mind, bear in mind, that be it allied health professional disciplines, epidemiology, public health, all these study designs, they are just providing us help to try and understand if 2 variables are linked in the cause-effect relationship. Is there temporality? Will A be associated with B? If you're looking at cohort studies or observational studies, now if you do an experiment, then you're actively manipulating a condition. Now you want to see that this variable, which I now refer to as my intervention, which is an independent variable, does this cause any change in my outcome variable, which is also known as dependent variable, which is maternal depression in case of Thinking Healthy program, or maternal psychosocial interventions, or early childhood development interventions. So then the designs will change into more experiment based, and then the methodology to ensure that this experiment of yours is not biased in any way. So you need to have these small little things ensured while you're carrying out that study, while you're conducting the study. So every small little piece that you pick up or ensure contributes to lessening the threat of any potential bias. It will help increase the internal validity, because if I hypothesize that intervention ABC, when given to maternally women who are depressed, who have perinatal depression, will improve. So if this is my if this is my hypothesis, then I have to test this hypothesis in an experimental design or quasi-experimental design, whatever you choose. Well, that's also an experimental design, or you do an RCT. Then every little step you will have to undertake to help improve the internal validity, as well as think of external validity, that once it's done, so what? Can this be extrapolated to other settings? Will this help or not, etc.? So we covered all of that. So I'm just emphasizing that the bottom line of all these research designs is that you're trying to understand relationship, the causality, the association, the risk, or effect of your intervention on an outcome. So it's an interplay of two variables at the heart. So because you're trying to test causality. And then we did talk about briefly about confounders, which are also known as covariates, which are also referred to as risk factors. So these are alternate yet independent variables, which can also explain your outcome variable. We discussed, for example, that I say that having more children is a risk and is independently associated with maternal depression. Prasanta says no, it's poverty, which is an independent risk factor, is associated with maternal depression. So we have two variables, both are independent, both are associated with depression. So this third variable or a triangle, an alternate variable which it also can explain an outcome, is known as confounding, is known as confounded variable. And we at length discussed that randomized controlled trials, because now you testing an intervention, you would like to control for all the confounding variables. You design your experiment in a way that all participants are randomly allocated to the treatment conditions. And simple, complete, open random allocation is the best, as we discussed yesterday. And that takes care of the baseline variables, which are covariates, which are risk factors, because we discussed that perhaps educated women, if they receive an intervention, they will be likely to have better outcomes. So you would want to have educated women equally distributed amongst both the groups so that there is no imbalance. So that at the end of the day, at the end of the experiment, both arms are equal in all respects. The only difference is that one receives your intervention, the other does not. And any change in your outcomes then will be attributable to your intervention, nothing else. So how do you ensure that the experiment conditions are met so that there is excellent internal validity? And if something, any project has, or any design or any study has good internal validity, rest assured, they will also have good external validity in some way or the other. The findings will be reliable. So anything that is valid is most likely reliable as well. And we'll discuss the other biases which we ensure that do not seep in when we are conducting our trial. So design, analysis, how do you choose people, how do you administer your randomization and allocation. How do you assess? Are they masked, blinded, not? So all of this will be taken into account. So be mindful of the very covert selection biases that can seep in. We discussed an example. If I were to select every person in the hospital coming on Mondays, on the surface, it looks like random, but it isn't. So the best is to have a list taken, the denominator taken, and then allocate them into various groups. That is known as simple, open, complete randomization. There are other ways of randomizing. I intentionally didn't go into that. If you're interested, I will be more than happy to discuss that. Any questions thus far? I will then take 10 minutes to walk you through with something that was left over from last yesterday, sorry. Yes, Prasanta?
So Dr. Siam, I'm just wondering if confounders and covariates are the same.
Yes, there are these covariates means that these variables are codependent. They are interacting in some way or the other. They are, so that's what we usually refer to. So I think I did say yesterday, Prasansa, that that causality, cause and effect. So the strength of this relationship, cause and effect, is on a continuum. So RCTs directly ensure that this is the cause of your effect. The intervention is causing this effect in your outcome. Whereas cross-sectional studies, because you're taking both your variables, your exposure, and your outcome at the same time, which is coming first, you can't tell. Yeah, you're limited. So they will coexist. They will be together. So they're then referred to as more co-relation, co-relates. So they're relating with each other in some way or the other. The better the design, this correlation gradually, when you can say that this variable does seem to predict an outcome, or this has a risk then you talk about association. So these are all the words I feel, and there are some other people who use these words slightly differently. For me, association means near definite cause-effect relationship. Correlation means more that, okay, there is some association, some level of association, not definitive, right? Risk is also, people call that as predictor variables. Yeah. So if I'm poor, I'm at risk of developing depression. So my being poor also predicts. So these are interchangeable words that we use. Correlates, risk factors, confounders, correlational variables. These are all the terms which just are describing that there are more than one variable independently linked with your outcome. So as you read these papers, some people use them in slightly different connotations, but that's how I use them. I hope that answers your question.
Yes, thank you.
Dr. Siham, can I ask a question?
Please go ahead, Prashani.
Yesterday, you mentioned that we are going to assess or analyze odds ratios under cohort studies. However, sometimes I have came across this odds ratio thing in cross-sectional studies. So does that mean that they Is it still applicable to cross-sectional studies?
It still is absolutely applicable to cross-sectional studies. And if you want, we can even today keep a little bit of time separately, or perhaps tomorrow we can pitch in. See, Krishani, odds ratio is just comparing two odds of two groups. Yeah. Yesterday, I think I did mention when I was talking about this cause and effect, the probability, the chance of them in a temporal relationship. So cause is affecting an outcome, or exposure and outcome. So we want to see the probability. What's the chance? Yeah. And chance is described either in risk. And I did tell you risk is an event happening versus the time, the number of times the event actually, you toss a coin. So once you get a head, second time you toss, you get a tail. So there are two events, there's only one outcome. Whereas odds is slightly different. Odds is another way of describing chance. The difference between odds and risk. Odds says that it is it's a fraction, or it's a ratio when an event happens, the number of times it happens, versus the number of times it does not happen. So in the case of this example of a toss of a coin, so in risk, I tossed it twice. Once it was heads, once it was tails. So the event occurred twice, but the outcome was once. So now in odds, there is one time it comes heads, that's my event. One times it does not come out as heads, that is my tails. So the ratio or the fraction will be 1/1. So the odds are 1 of having a tail or whatever event you describe, either tail or heads. So in terms of odds, the chance is when you describe it in odds, so it's 1. Whereas when you describe it in risk, it's 0.5 or half or 50-50. Yeah. So that's the difference of describing risk and odds. But both are talking about chance. They're both talking about probability. Now, when you compare two groups, yeah, so each group will have a outcome happening or not happening. So event happening, not happening. So any design which is also telling you that there is an event, whichever event you describe, depression, not depressed, depressed, not depressed, yeah. So you can create a risk from this. So event, the number of people that you have, the number of events that you have. So denominator becomes your people, your event becomes your depression, becomes your numerator. So that's a risk, right? Now, in the other group, which you're comparing with, you can create another risk. And then once you compare these, you put these risks in a ratio. So that's a risk ratio, right? And you understand it through confidence interval. The same happens when you do with odds. Odds is that event happened, event didn't happen. So now your odds description in one group is slightly different, and the other group is different, and then you can put them in a ratio. So that's odds ratio. So any study can report odds as well as, but case controls generally, traditionally, they report or cohort, like you said, traditionally report on. And these days, what I heard in London School, one of his lectures, Richard Hayes, he's a great person. He's remarkable. His book on cluster randomized control trials. So now there is a recommendation that even trials try and report relative risk ratios as compared to odds ratios, because they describe certain, it's slightly different what odds tell you versus risk. Risk is simpler in terms of interpretation, but odds is slightly complex in terms of its interpretation. The number of times an event happens versus a number of times the event does not happen. So that description is slightly different. So I hope that is slightly clearer. You have to spend a little time thinking through what chance is about and how it's described, what's risk, what's risk ratio, what's odds and odds ratios, how confidence intervals are used to understand if there is significant odds or ratio or risk ratio. The book that I referred to, David Bowers, Understanding Clinical Papers. There's a chapter on that. Really easy to follow, quotes actual examples from studies, tries to describe and tries to articulate how you say when you're describing the findings in odds and when you're talking about risk. So what does it mean, etc. So I'd encourage you to have a look at that chapter. Hope that answers the question.
Yeah, thank you very much.
So just bear in mind that these are all expressions of chance. The chance of one thing, one exposure, linked, associated, predicting, confounding, being a correlate, being a covariate. So the chance of this happening, these two things being associated, linked, predicted, whatever the word that you want to use. So you describe it in risk, you describe it in odds. So it's an expression of your probability of these two things being in a temporal relationship. Right, so let me quickly walk you through with a couple of more designs that we didn't cover yesterday. And we will not spend much time. I just want you to have this in your vocabulary, even if this means that you don't fully, at this point in time, don't fully, and I'm just getting the presenter's view, and now I will share the screen. Okay. Are the set of slides visible now?
Yes, it is.
Okay, so yesterday we left off by looking at our how do you evaluate a complex intervention, and we looked at MRC guidelines, and we looked at that it's a cyclical, depending on where you are with your evidence. You can do feasibility or pilot studies. We did mention the slight difference between the two. We did we did pick up that MRC tells us the framework or guide to evaluating complex interventions, because there's a development phase, then there is a feasibility phase, then there is an evaluation phase, and evaluation phase usually means definitive trials. And then, which is as you take those trials into more real world, less controlled environment. So you start moving from more efficacy towards more effectiveness spectrum. And once you get into the real world, the effectiveness is starting to convert into more implementation side of things. You know, you take it into the real world, real actual programs, start delivering them. Now the evaluation will always be needed. So are there study designs which will help me as a public health or as a global mental health person to keep evaluating as robustly as possible even the implementation phase of my intervention, because the minute I take my intervention from very controlled environment where I can control for my inclusion, my exclusion, I can send out my research staff to, like yesterday, I think Rashani asked me, or Asiri asked us that, what's a good time frame to assess that it's sustainable? Is it 6 months, 1 year, whatever? Yeah. So once the research team, I can control my research team. They are on my payroll, etc. They're invested. They're doing PhDs. So the program will get pushed and will have absolutely best possible fidelity. But once you hand that intervention over to a program, say the Ministry of Health, say the department who will eventually be training the community-based voluntary females in Nepal, or the health promoters in Sri Lanka, or some peers in slums in Dhaka, and these peers are governed, are held by, say, the Ministry of Health or by a university. Then the researchers' interface gets diluted. The control or the effort to keep the quality going does seem to waver. Then what do? Do we stop evaluating? How do we know the implementation is taking place properly? It's still taking place in a fashion where it's not only helping my clinical outcomes. Is it now getting implemented? Is it getting reached to the people that require it? In a study design, I can recruit people. Now, is the program recruiting people or not? Is this delivered through quality or not? Yeah. Are the people who are delivering it competent? Is this causing enough difference in my clinical outcomes, which I did see in my much more controlled effectiveness trial or efficacy trial, which I evaluated. So as you start changing the context of, and you start getting into more real world, more implementation, please bear in mind, the evaluation will never stop. It should never stop. From a non-academic perspective, programs do monitor, do evaluate. You must have heard the term M&E, monitor and evaluate. So many NGOs, many district health information systems do monitor and evaluate, right? So they're constantly in a phase of evaluation. So as an academic, as a person who's trying to scale things up, we yesterday discussed what scaling up means. Scaling up just means that you either increase your number of people who are going to deliver it, that scale up. If the number of organizations that you involve, that scale up. The number of participants that you involve, that scale up. So again, to an intervention defined as complex, scale up so has the same component. The more people you want to reach, that scale up. The more people you want to train, that scale up. The more health systems or more sectors you want to involve, that scale up. So scale up can be defined in a number of ways. If you want to add a component into the intervention, that's also scaling it up, right? So scale up can be defined in many ways, but please bear in mind, evaluation will never stop, right? Here's now the catch. Randomized control trials, yesterday we saw that they require quite a bit of stringy methodology. Yeah, they require quite a bit of quality assurance in terms of having them internally valid. Yeah, how do you select people? How do you recruit? Is there bias? Etc. You know, there's small little nuances that you need to be mindful about. But those are all talking about one and only one thing, which is, does my intervention affect my outcome, which is depression or which is early childhood development? So this is more clinical, right? So now when I go into the real world, now there are other questions that I am also asking. I'm asking, is the intervention being delivered to the people who require it? Is the program doing that? So I'm talking about reach. It has no bearing on my clinical outcome or my clinical effectiveness of the intervention, right? Is this being delivered as intended, as per protocol? So that's fidelity. And in number of discussions which we've had, fidelity, the construct of fidelity will involve a number of things. Is this being taken up by the people who should deliver this? So adoption, it has nothing to do with any clinical outcome. Is the depression going down? Is the disability going down? Is the function coming up? Right? So these are all clinical outcomes. And then there are these more implementation or programmatic, or if you would like to call it, more procedural, more process related outcomes. So RCTs just look at clinical outcomes. Yeah, is the depression treated? Has it gone down? Has the function that improved, etc.? Or are these are all clinical outcomes? So are there designs which will help me still do an RCT if I wanted to, depending on the level of evidence, yet simultaneously also help me collect these programmatic, more procedural, more process, more implementation related outcomes as well. So what are those designs? Because RCTs clearly are deficient. I'm saying this again. Please don't think that it's a contradiction to what RCTs do in terms of showing cause and effect. They are still the gold standard, but they start to fall short once you take your intervention into far more real world and you want to scale it up, still want to assess if they are clinically working. You still want to assess if now they are also working in terms of the implementation, right? Are you clear till now? Raise your hands if you're clear so that now I get into that. That's the preamble to the next couple of slides. Right, good. Thanks, Prashani. Good. Pragya. And I think Prasansa, clear? Okay, good. Cheers. So I've just to look at this slide, what is scaling up? I've already talked about it. So it's a deliberate effort to increase the impact of successfully tested health interventions, right? So that the benefit can be spread to more people and to help the policy and the policy take up, practice shift, so program development on a lasting basis. This phase of evaluation where the RCTs sort of get limited, they don't assess what is more implementation side of things. So since the last 20 years, people are trying to talk about this. Yeah, people have started talking about that this is an altogether a different discipline where clinical world meets the more real world when you're trying to increase the impact of your interventions, you're trying to scale it up. Yeah. So the term implementation science came into more relevant. So implementation science is just a discipline which is trying to cater to this real world programmatic on the ground implementation of known effective intervention. Please keep in mind the MRC cyclical model. So you've evaluated an intervention in as much as controlled environment. You've ascertained that this is effective. Now you want to take this to scale or scale it up. This is where the implementation science steps in, which is augmenting your clinical trials discipline. So implementation science is the study of the methods that you promote, that you use to promote the integration of research findings and evidence into healthcare policy and practice. Because now you say that the Thinking Healthy program, or you say that the peers are effective in delivering intervention in Dhaka slums. Ministry of Health, dear colleagues from the policy side, please take this up. Yeah. So that's your discourse. So implementation science helps that to bridge that gap for people to be able to take it up within their policy and practice shift. Implementation science is the scientific study of methods to promote uptake of research findings into routine healthcare, be it clinical, be it NGO sector, be it the policy context. It seeks to understand the behavior of healthcare professionals. Yeah, like I was saying, is this being delivered as wanted? Is this delivered to the people as we intended it? Or have the people adopted this practice shift? Yeah. So, and there have been a number of, there is growing sort of literature around implementation science, implementation research itself. So WHO is putting up, reports and guidance on implementation research. Vensing and colleagues have written quite a bit around implementation science and the themes, sort of themes for future research. So they talk about how the implementation should assess certain things, how this field is more turning into when you implement, how do you titrate it? So Siham may not need just Thinking Healthy program. Yeah, I may need something else. So more personalized. It's a new term, new sort of emerging relevance of personalized medicine, personalized medicine approach. Last but not the least, implementation science, because it's now real world, it's more policy interface, it's more practice interface. Cost, the economics around these interventions should not be overlooked. So WHO, people like Wensing and others are advocating this science. Whereas I like this particular diagram, and it just sort of conceptually gives you the idea that you do your in your MRC guideline framework. So you do your development work, you do your efficacy trials and studies, and then you start getting into the more implementation side of things. You step into the real world, do effectiveness studies. Yeah, for example, if you are in Dhaka slums, if you're in Nepal, if you're working in Sri Lanka with health promoters, or Huma is working with the lady health workers. Now, lady health workers, health promoters, peers you select in Dhaka, or the female voluntary staff, these are already people who either exist on the ground through some ministries, programs, etc., or you're going to find them and make them work with some existing health structures, right? So the minute you do this, you've started going into the real world, and that's where your effectiveness starts. Yeah. Now you're out of the clinical into the more effectiveness, more already in the real world implementation side of things. And then you help people, the programs, adopt your intervention. You ensure that they are sustainably taken up, right? And then more and more and more people start getting reached through this intervention. So this red outline box, this process is usually called as dissemination and implementation studies. Yeah. And once you start interfacing with the more implementation side of things, as well as your clinical outcomes that you're still interested to know, is depression being helped by my intervention delivered through a program or not, through lady health workers or not? Yeah, these are still relevant clinical questions, but you're also asking some implementation questions. Yeah. So here's the hybrid designs that people have now started since a decade now talking about. The hybrid designs is that you want to test effectiveness, but also understand more implementation. So there's a hybrid design. They have a dual focus, and they have a dual focus because it's still a science of evaluation. So there has to be some a priori hypotheses or conditions. Yeah. So when you assess either the intervention's clinical outcomes or the intervention's more implementation outcomes, so you start thinking a priori, right? There are three sorts of designs. Let me get the chargers. My laptop's going a little. So there are three designs that is hybrid design.
Dr. Sinha, your voice is low now.
Why should that be?
Now it's better.
Right. Thanks, Nida, for pointing that out. I hope I hope this is audible.
Yes, it is.
Great. Right. So I am still interested in effectiveness, but I'm also interested in the implementation as a priori, right? As a hypothesis that I need to test. So three types of designs come to my head and advantage. And people like Karan and colleagues have been extensively debating about these hybrid designs. And one of the designs is still a trial. a design that's known as type 1 RCTs, which is testing your intervention, clinical outcomes, but is just gathering information on implementation outcomes like adoption, reach, competency, fidelity, etc. The more procedure and process related outcomes. But your main focus is still interventions effect on clinical outcomes. Type 2 RCTs in the hybrid design spectrum are studies which have dual outcomes. Both are sort of primary outcomes. One is the clinical as well as your implementation strategy. So dual emphasis, equal emphasis. So that's type 2. The type 3 design of effectiveness implementation hybrid design is where now you've established that the intervention, no matter what the scale is when it's in the real world, still has its effectiveness established. So the clinical outcomes become secondary. Now the primary outcomes become your implementation strategy. While you just keep observing, just keep gathering clinical outcomes. So as generally programs do within a district health system, right? So they're not too interested in gathering very granular information on depression, etc. So they will just look at the prevalence, but they will have who are the people who are trained, the number of people who quality, etc. So those are known as type 3. Any questions so far? And Prasansa, I hope now it's slightly clear where Karan's designs come into play, because you were looking at them and you were getting a little confused. So this type of designs come into play when you've established fairly enough and you're doing a definitive trial, but you're doing it in a real world, you're trying to scale it up. Yeah. So I hope it's clearer now.
Yes. Can you go one slide back, please?
Mm-hmm.
So if you look at the flow diagram on the right, does it
Mm-hmm.
mean that hybrid design studies only comes after there is enough evidence on efficacy and effectiveness? Or
Exactly.
does it come?
Exactly. It does, because you need to have this phase, yeah. And again, effectiveness studies, it's entirely, there's no sharp boundary either, yeah. Like I was saying, that the minute that you start interacting with the people at the ground, on the ground level, be it in Nepal, be it in Bangladesh, you've already taken it into the real world. It's no more clinical settings. It's no more. So it is an effectiveness study if it's a trial. I'm talking about a trial interfacing with your programs, with your female voluntary staff, even peers working in Dhaka, working alongside with some health system structures, right? And you're doing a trial. So that is an effectiveness trial, right? Once you establish that, now you are scaled up. And scaling up can mean many things, Prasansa. More people to reach, more programmatic people to train, because the more people you want to reach, the more people you want to train. Now you've stepped into more scale up. So this is where hybrid designs will come into play. You can choose. For example, after all the feasibility and studies in Nepal, the first definitive trial that you do, you can probably start looking at something like this. Yeah.
Mm-hmm.
You test your effectiveness, your clinical outcomes, and you also gather information. I probably might start thinking every program is an evidence-based, the feasibility study that you've done shows that these workers, volunteer workers, can be trained competently, and when they deliver the intervention, there seems to be some trend in improvement in depression outcomes. Yeah. Arguing that THP is an evidence-based, my feasibility study in Nepal is very encouraging. I will directly step into type 2 RCTs, effectiveness hybrid, yeah, where I will look at implementation outcomes equally. Yeah. So it is up to you how you rationalize and how you justify using one of these. I hope that clarifies.
Sure, thank you.
Right. I won't get into much further detail in this, but I just want you to have at the back of your mind that when we look at this model, this is talking about a single intervention. You test its efficacy, you test its effectiveness, you take it to the policy people, you ensure that they have enough adoption, you train them enough way that they become more sustainable, they take it up on their own, and they start moving upwards towards more. So this is the trajectory of just one intervention. Now, what will happen in the real world? There is usually more than one intervention at play, right? So when I ask that, how will the program detect people who require this intervention? Now, detection itself is another intervention. You need training, you need supervision, you need monitoring, right? So how will that happen? So immediately you're talking about another intervention alongside this intervention that you're trying to scale up, right? So now it's not an intervention. Now it's become a program which has more than one intervention. So do you stop evaluations? Do you stop evaluating programs? What's the method to do that? Once your intervention starts becoming more complex, takes to shape up like a program, then the implementation science offers more program science related approaches. And program science is an offshoot of implementation science. Implementation science looks at one intervention, program science looks at a program of interventions, yeah? And it is more interested in more quality, more coverage, more policy, how is policy being advised, and how does the program feed back into titrating? It's like a program of interventions. So think of MNCH. So MNCH has maternal newborn child health. It has antenatal, postnatal, it has vaccination. It's a complex program. And usually 1 or 2 or 4 or 5 types of people are involved in it. Do you stop evaluations? No. You still evaluate them. Now program science is the approach. People like Aral and James Blanchard, he's a good colleague, he's based in Canada. He's a big name. He's a big advocate of program science. So he's trying to push this agenda onto the global health arena of doing programmatic program science. And by the way, program science evolved from HIV program. So any questions so far? Hi, Dwalo. Sorry. Morning. Hi, Nagendra.
Hi, Shyam. Hi, Shyam.
Dwalo, can you hear me loud and clear? Dwalo, can you hear me?
Yeah.
Sorry, I was just finishing up a little bit of recap from yesterday. There were a couple of things that had we had left off.
Okay.
So very quickly, I'll introduce. Well, they all know you. I'd already introduced you yesterday. So, dear fellows, here's Professor Dwalo Wang. He's a professor at the Liverpool School of Tropical Medicine. He's a dear colleague and a great ally. He is our go-to person for all our statistical conundrums. He's helping us with our enhance trial as well as our trial statistician. He's a lovely person to work with. So he'll be walking you all through the power size implications and calculations. So, Dwalo, we have Nagendra also joining from Nepal. He's our site lead, so he'll be listening in. And we have today we have a couple of apologies from a couple of fellows. They weren't feeling well. So, and just as a reminder, Dwalo, we are recording this session. I hope that's fine with you.
Okay, fine. Thank you.
Cheers. So over to you, Dwalo.
Okay, thank you very much, Sneham. Sorry, I'm a bit late. Okay, shall I switch off my video so that that traffic flow smoothly, or is that okay here? Okay. Or better let me switch off my. Okay, can you see my slides properly?
Yes, Dwalo.
Okay. Thank you very much, Snehal, for inviting me to talk about sample size calculation. Sample size calculation, whether you like it or not, we all have to face, when we do, our clinical research, whether it is a randomized clinical trial or observational study, okay? When we submit our manuscript, so will be reviewer will raise the issue. How did you do your sample size, calculation or determination or something like that? So that is, the topic I'm going to talk about. I'll introduce, some terminologies in sample size calculation, and I'll list the questions to ask when we do sample size calculation, and show you how to do a sample size calculation and how should we report the sample size calculation in our manuscript. Okay. So why sample size calculation is important? Okay, let me give you an example here. So this is, they are the results from 7 simulated trials. So we are going to, let's say, we are going to conduct a randomized clinical trial to assess a drug, that's a weight reduction drug, whether this drug is going to work or not. So let's say, assume we have 2 kilo reduction in the active group and 0 in placebo group. So with different of sample size, if we perform a statistical significant test, we have different results. If sample size is 20, that means each arm we have 10 subjects. So let's assume the sample 1, 10 subjects, active group, the 2 kilo weight reduction from baseline with standard deviation as 10 kilo. And in the sample 2, arm B, similar, we have 10 subjects, but no weight reduction, but we have identical standard deviation. And if we have these parameters, we know we can do perform a t-test to test whether this 0 and -2 are statistically significant different. Okay, in Stata we use the test I command. 10 means sample size, -2 that's mean, and 10 it means the standard deviation. And similarly, we have the 10, 0, 10 for sample size, mean, and the standard deviation separately in arm B. And then you see the results. We got a p-value 0.601. Okay, that is how this 601 from. If we increase sample size to 40, the p-value will become 0.5309. And then we further increase sample size to 400, 200 in each arm. We'll get a p-value 0.0462. That's slightly smaller than 5% significance level. We can declare in this trial the difference, 2 kilo difference is statistically significant. And then we go to extreme, increase sample size to 2,000, 1,000 in each arm. We'll get a very, very small p-value, smaller than 0.001. So from this example, we say we see that the p-value from for the significant test is related to the sample size. With a large sample size, p-value becoming smaller and smaller. So sample size is the sample is the number we need to we can reach the statistical significance for this 2 kilo difference. Okay, so that is if sample size is too small, we'll never see the significance. If sample size is too large, we see that the p-value will be very, very small. But the issue is if we have too many subjects, we do not have funding to do the study. Also, there is an ethical issue there. Okay. Now let's give you three more examples that actually published the studies. The first example tells us the false negative results due to small sample size. We have 2 trials. One is called the America trial, another is called the CLASP trial. One is not large, one is small. All trials were testing the antiplatelet agent for reducing preeclampsia. The primary outcome in these 2 studies were preeclampsia. America trial is a small study. It was observed 26 events, preeclampsia events in antiplatelet group, but 30 in placebo group. If you look at calculate the p-value is 0.57. So this p-value is very large. So the clinicians were put off by this large p-value, not significant, far from 0.05, 5.05. The statistician calculates odds ratio is 0.85 with confidence interval from 0.49 to 1.48. So there was a communication, the chat between the clinician and the statistician. Statistician asked the clinician, do you think the 15% of reduction in odds of chlamydia is it's clinically important a lot. That clinicians say, of course, it will be clinically important. So statisticians say, if you want this significant, we need to increase the sample size. That is why CLASP trial was conducted. Based on this time, they recruited over 8,000 patients. This time, P1 0.029, smaller than 5% significant. With odds ratio 0.88, that's 12% of reduction in odds. Okay. From these two examples, we can see similar estimates of treatment effects were observed in two studies. But the America trial did not produce convincing results because of low power, because of small study always are subject to selection bias, subject to confounding imbalance due to imbalances in some characteristics of patients at the baseline, and also due to random error. But the CLASP trial is a large study. It has large power, less selection bias, probably less confounding issue. So it produce convincing results. That is negative results due to small. It is actually this drug, this antiplatelet agent reduces the preeclampsia. The America is too small to detect that effect. So another example is the opposite. It's a false positive results due to small study. So that was a pilot study. There was study evaluating the effect of donor-C alpha against placebo in terms of hospitalization, exacerbation among patients with chronic bronchitis. So that is a primary outcome is hospitalization of exacerbation. This is a primary outcome. And in a small pilot study of 244 patients, deaths within 6 months was only 11 patients in active group, but 27 in placebo group. So that means the reduction in active is nearly 1/3 of that in the placebo group. And the p-value was calculated as 0.002. So this gives a very, very promising results. But regulatory authorities will not accept, this your registration based on this, pilot feasibility study without any power calculation. That is why a larger study, large multi-center study was conducted in 5,188 patients. And we know for this kind of larger, study usually lasts about 4 or 5 years. There are always some planned interim analysis. One of the interim analysis occurred in July 1995. They look at deaths within 3 months. There were 197 deaths in active group, but 163 deaths on the placebo group. You see, this time the story is changed. Even direction is in favor of placebo. It was expected, the active group should have less deaths than placebo, but actually what happened, is that more deaths in active. So this, study, because, if this trend is, going to continue, there's no way to reverse even the direction. So this trial stopped. So this two trials tell us, pilot study, a small study, have a high risk of positive, false positive results. Maybe due to selection bias. Maybe for this study, doctors select patients in favor of, the treatment, your ACA treatment. Maybe some confounding issue. So the results are not reproducible. That's the second example. And another example is a trial published in New England Journal of Medicine 2019. That is on the drug of atorvastatin. I think is this is a negative trial. If we look at the treatment effect, the primary outcome was a composite endpoint of you see here primary outcome. Where is the primary outcome? Primary outcome is some kind of MACE composite endpoint, but it's turned out the hazard ratio is 0.66, p-value is 0.1, much larger than 5%. So this is negative trial. There's a low effect. Actually, if we look at the 0.66, that means the primary endpoint, is risk of primary endpoint reduced by 34%. But the p-value is large because sample size is too small, about 420 something in each arm. If the sample size increased to 500, significance will be reached. So this is the fourth negative result. Okay. Now from this example, so we see, that's really important. We have a proper, sample size so that we can, produce convincing results. We can avoid false positive results or false negative results. Okay. To do sample size calculation, we have two very important, terminologies. We need to be very familiar with. To do that, we need to go back to refresh ourselves about a hypothesis, test. Statistics textbooks tell us, when we do a statistics test, the first step we need to set up a null hypothesis. That is, let's say we are comparing two means. Mu1 equals mu2, no difference between two means. And the alternative is they are different. Okay, they are different. So let's put this way in the t-test to compare two means. We set up null hypothesis. This is something we are trying to reject. This is something we are trying to accept. Okay, based on this assumption, no difference, we can derive a statistic, use statistical formula. That is T formula. So this formula requires the sample means, sample combined standard deviation, and the sample size. Okay, if we have a sample size, we have the means in each arm. We have a standard deviation in each arm. We can calculate this t value, and then we compare with some threshold t value. So we can get the p value. P value is the probability of obtaining an effect. Okay, at least as dreaming, and falling in both sides of the tail. That is p value. With this p value, we can now decide whether we should accept or reject this statistical hypothesis. Okay, so we have the this is assumption. Whether this is true or not, there is no effect. But whether there is no effect or it has effect, we don't know. It's just like a black box. Okay. Now what we can do is we do statistical analysis. We can make a decision based on the statistical results, precisely based on the p-value. So from a statistical test, we can either reject the hypothesis, null hypothesis, or do not reject, depending on the p-value. Okay, if p-value is less than 5%, we reject. If we p-value larger than 5%, we just do not reject. Okay, these are two statistical conclusions. And also, in the fact, maybe, two true situation. One is, true, that's low effect, okay, equal, low effect. Or the false, actually, the active drug is doing better than placebo. That is false, or in other words, is effective. Now, if, if you say no effect, and we no effect, but we reject, we say is effective. So we'll make an error, we'll make a mistake. This is called a temporal error, often called alpha error, or false positive results. If we are patients, we are consumer, so we are given, fake drugs. So that is a consumer's risk. So if we made a temporal error, we take, our effect drug as effective, that we put our customer, our patient interest at risk. Okay. If we do not reject, we say that is no different, no effect. That's correct decision. Okay. On other hand, we low hypothesis, low effect, but actually the drug is effective. So we just reject that one. So we make a correct decision. That is power. That is power. Because the probability, so that the power is 1 minus beta. What is beta? Beta is this one. When it has effect, drug is effective, but you say, it's not effect. So that is the false negative results. As far as the, pharmaceutical company is concerned, so my drug is effective, but you perform wrong statistical analysis. You say my drug is not effective. You put my company's, benefits, my company's, interest, income at risk. So that is we call consumer's risk. So now we need to, decide. We need to strike a balance. What should we do? Whatever we do, we are running two kind of risks, or whether we compromise our consumers' risk, or we compromise, manufacturers' risk. Of course, from an ethical point of view, we just want to, look after our patients. Patients are more important, than manufacturer, pharmaceutical industry. So we usually let beta error slightly large. Usually we let beta set as 0.2 or 20%. That means 20%. That means 1 in 5 or 2 in 10. 2 in 10. So we do make mistake, but the mistake could be 1 in 5. This is large, 20%. This is pretty large. But on other hand, for we really want to look after our patients. Usually, we want to protect our patients. We want to avoid fake drugs in our market. So let's make the rule criteria rigid. Usually, we take 5%, 5% as alpha error, type 1 error, or so-called false positive results error. So that means 5%, 1 in every 1 in 20, 1 in 20 compares 1 in 5, 1 in 20. So we consider more interest of our patients than manufacturers. Of course, if we want to avoid or control beta error, that means you need to increase your power, or you can increase power to 90%. In that case, that beta error is 10%. Or if you want to similarly like 5% for beta error, that's fine. That means your power is 95%. Okay. So that is two concepts we need to be familiar with. Okay, now we need to to do sample size calculation. I'm working as a statistician. I have been collaborating with many clinicians, cardiologists, mental health experts, gynecology, oncology, oncologists. So they always come to me for sample size calculation. Okay, to do sample size calculation, I need to get more information. I usually ask, following 5 questions. What are you going to do? What is, your study? Are you going to do a trial or do observation study? What's your primary outcome? What is the clinical meaningful difference and its variation? What is the alpha error? What is the beta error? Do you need to take into account dropout? So these are basic questions I need to ask before I do any sample size calculation. Let's look at these questions one by one. First, study design. Okay, we know for clinical studies, for medical researches, they can be classified into 2 broad categories. One is so-called intervention studies. Okay, intervention studies. So we want to test our medicinal product, medical procedure, medical device, vaccine, nutritional supplements, our CBT, our single health, different intervention packages. That's an intervention study. Or we just want to observe our subjects passively without intervening their life. That's what we call observational studies. Okay. For intervention studies, according to the randomization methods, we can classify the trials into 4 broad categories. First is so-called parallel design. Could be 2-way parallel, or 3-way parallel, or 4-way parallel. Okay, so if you are randomized in A, you just stay in A throughout of a study. If you are B, you are required to stay in the B during a study. That's a parallel design. Another is so-called crossover design. Crossover design. When we do crossover design, let's say if we want to do a 2-by-2 crossover, so that's 2 treatments in 2 periods. So we randomize the sequence, randomize patient into 2 sequences. One is AB, another is BA. So study will be conducted in 2 periods. In period 1, half of patients will receive A and half will receive B. Okay, and then we have a so-called washout period, so that the drugs can be totally eliminated from our bodies. Okay, after the washout period, those who received the A in period 1 now receive B. Those who receive B now receive A. So that is ABBA. So this is so-called crossover design. Could be 2-way 2-by-2 crossover, 3-by-3, 4-by-4, or could be any other crossover designs. Okay. Another is so-called factorial design. Factorial design is simply put 2 trials together. Let's say we want to assess 2 drugs, similar drug. One is aspirin, another coraligin. We want to see, whether these 2 drugs could reduce some cardiovascular disease. And the traditional way is we just to do 2 trials separately, two parallel parallel designed trials. But if we do this way, we have to, it will take a long time. Will take a long time. And but because the primary endpoint is the same for two, drugs, the study populations are the same, and other aspects the same, just like the same protocol for two different drugs. Why don't we combine the two trials into a single one? So that is factorial design. Okay. That's one stone, two birds, factorial design. Another is cluster randomized trial. Cluster randomized, we have done at your institute, you have done so many cluster randomized trials. Okay, the randomization unit is not an individual subject, but is the village. Okay, or clinic. Okay, they are the cluster randomized trial. That is classification according to the randomization methods. If we classify according to the comparative purposes, they can be classified into three categories. One is so-called superiority trial, superiority study. We want to show why treatment is superior to another in terms of primary outcome. Or we want to demonstrate two interventions produce similar effect in terms of primary outcome. Similar, why should we do it? Maybe similar because the in terms of efficacy is similar, but in terms of safety, the new drug is better. Or in terms of cost, the new drug, new intervention is better. And another is non-inferiority. Or maybe this drug A is worse, not worse, is worse, not but it should not be inferior to the existing drug, so long as that difference is below certain acceptable margin. That is non-inferiority trial. So we times four previous four four designs by 3, so we have 12. We have at least 12 possible designs. That's a non-inferior, parallel superiority design, crossover superiority design, factorial superiority design, cluster-randomized superiority design, etc. So you see, we have different, type of designs. So that is broadly classifications of randomized clinical trials. And for observational studies, broadly, we have 3 categories. Cross-sectional study, we want to evaluate prevalence of disease at a particular time point. Or we want to, compare, look at the relationship between one variable and another. They all can be done within cross-sectional study. Another so-called cohort study. Okay, so we want to follow up a group of subjects for a certain time period. Okay, like a Framingham Heart study. It has been going on over 70 years. Okay, or case control study. We have some cases, and then we found some matched case cases controls. So that is case control study. So as far as sample size is concerned, you need different for different designs. The sample size calculations are different. So before to do any calculation, you must ask yourself. You must ask your collaborators what precisely your design is. If it's a trial, it's a parallel design or crossover design. Are you going to do superiority study or equivalent study or non-inferiority study? So that determines the formula, determines what the parameters you needed to collect for the sample size calculation. Okay. And the second question we needed to ask is the primary outcome. So what is your primary outcome? In any clinical studies, okay, we should have a primary objective. the most important objective you want to address in this study. And corresponding, this primary objective is a clinical question, but we need to, in order to address this primary objective, we need to convert this clinical question into statistical question. So that means, in other words, we need to have a measurement to measure, whether, our objective, primary objective will be achieved or not. That's we need the primary outcome. Is, let's say, if we want to evaluate, whether a medical device could reduce all-cause mortality, that is primary objective. Now you need to convert this clinical question into a statistical question. My primary endpoint is all-cause mortality at 1 year. Okay, at 1 year. And so we need to define clearly: is 1 year and 6 months or 24 months? We have to be clear. So the primary outcome is a data. It's a data. If it is a data, it could be in different formats. Okay, it could be a so-called quantitative data, as we call continuous outcome or numerical data. For continuous outcome, we can calculate the mean, calculate the standard deviation. So we usually to compare two means for sample size in statistical analysis. Correspondingly, if we want to do sample size calculation, you should base your calculation on comparing two means. Okay, or primary outcome could be binary outcome. Like even patient died a lot, whether the events occurred or not. Okay, is binary outcome, so we can calculate risk difference. So for each arm, we calculate the probability of events. That the probability is risk. Now we have two risks. We can subtract one from another. That's risk difference. Or we divide one by another. That's risk ratio. Or we calculate odds first for each arm, and then divide by one by another. That's odds ratio. You see, if you calculate sample size, we have different choices. We can calculate sample size based on risk difference or risk ratio, even odds ratio. For time to event data, or often we call survival data, usually we compare incident rate ratio. We calculate risk incident ratio or hazard ratio, or difference in cumulative event rate. Or we can even compare the median survival time or mean survival time. Okay, different choice of statistics you are going to compare, you are going to measure to evaluate the treatment effect. The sample size calculation will be different. Okay, for counter data or recurrent events, we calculate incident rate ratio. Okay, now let's further refresh ourselves. Let's say if we want to compare different outcomes. Okay, now you can calculate different that is delta we are really interested in. Could be difference, could be ratio. Let's say if mu n and mu s are the mean of outcome. So if it's binary, then mean is proportion. For example, proportion of deaths. Okay, in two treatment arms. Now the null hypothesis is they are equal. Okay, two proportions or two mean values are equal. So that's one mu equals mu s. So if we do smart change, it could we can say is move this to left side, so that the mu n minus mu s equals to 0, or mu n divided by mu s equals to 1. And that is no hypothesis, no difference. Now, alternative hypothesis would be, they are not equal, or according to this one, that means mu small is small than us or mu larger s. horizontal, we have three possible, alternative scenarios. Okay. Now we can calculate, the p-value or confidence interval. If confidence interval, is large 0 or does not include 1, that means no difference. Superiority cannot be achieved. If p-value less than 5%, superiority can be declared. So that is basically, if we put it, when you do sample-size calculation, okay, you should in your mind, you should have such a hypothesis ready. So this is the test I'm going to perform. When I finish collect my data, this sort of test I'm going to do. Okay, so it's important to have this kind of framework where before you do sample size calculation. Okay, and the third question we need to ask is, what is clinical meaningful difference and its variation? Okay, so that is if you want me to do a sample size calculation, you have to provide me with some parameters. I cannot manufacture some sample size from nowhere. Okay, let's say we are going to do a two-way parallel superiority trial. We are going to compare active group A and control B. Primary endpoint is changing from baseline in brain amyloid levels at 24 weeks. So this is a continuous outcome. So from empirical studies, we know that the difference could be 0.2. Standard deviation is 0.1. Okay, based on these two parameters, we can do sample size calculation. Now, so the formula is very simple. It's just experience. So where is this formula from? This formula actually is from the t-test. Okay, when we perform a t-test, you see we given number of sample size, given the means in each arm, given standard deviations in each arm, we can get our t-value. Now the situation is changed. It's different story now. Now we do not have sample size. But we have the mean difference. We have the delta. We do not need to know, what is the mean in group 1, in group 2. But of course, if you have, that's fine. But we only need to the delta. What is the difference between two arms? Okay, and we also need to know the common standard deviation from the two arms. Okay, apart from these two parameters, and we also have two z values. Z values, they are from the normal distribution. So alpha is alpha error. Okay, we have from this alpha we can determine that, and for beta we can determine another z value. We need to introduce this into this equation. For the significance level, we usually take 0.05. Correspondingly, we have the z value 1.96. Okay, so that is the conversion. We just treat alpha 0.5. If you treat 0.01, that's fine. That would be the z value would be 2.558. The issue is if you use alpha 5% as a significance level, when you do your sample size calculation, when you do your eventually you do statistical analysis, so the significant level is 5%. If you calculate the p-value is p-value is 0.4, you will get a significant result. If you calculate sample size base alpha as 0.01, 1%, eventually if you do statistical analysis, so your p-value, calculate the p-value should be compared with 0.01, but not 0.05. Okay, if your p-value 0.04, so that you got non-significant results. So be careful. So is sample size you have to be careful in terms of choosing the alpha significance level. It's safe. You always take 5% as a significance level. Okay. And we mentioned earlier that beta is the type 2 error. 1 malus beta is the power. Usually power, we take a power at 80%. 80%, and that means alpha is 0.2. 0.2. Now from this formula, we can see the relationship between the sample size and these 4 parameters. Okay, first let's look at the delta. Delta is inversely related to the sample size n. So that, in other words, the larger the difference, the smaller the sample size, or smaller sample size, the large sample size. Small difference, larger sample size. Large difference, small sample size. So this is when we do sample size calculation, we always too ambitious. Believe treatment effect is large, so you will get a smaller sample size. But it would be better to be conservative, use a moderate or even small or worst scenario case to calculate a conservative or optimistic sample size. Okay, other 3 parameters are positively related, proportionally related to the sample size. Larger the variation, the larger sample size. Larger z value or smaller significance, large p-value. Larger power, larger the power, smaller the beta error, the larger the sample size. Okay, so you need to remember this, and they are very, informative. You see from this formula, you can see very clearly the relationship. Okay. Now, in terms of sample size calculation, it's very simple. For that formula, we can I wrote Excel software. So I just introduce the parameters into the Excel form. So these blue cells, they all can be varied. You can enter the value. Let's say 0.04, standard deviation 0.1, 0.1. So ratio here is 1 to 1. You can change 1 to 2 or 1 to 3. And the significance level 5%, power is 80%. You will get nearly 98 patients per arm, or total 196. Or you can calculate the sample size using some online calculator. This is one. This from City University of Hong Kong. How to calculate sample size for two parallel superiority trial. Okay, you give the value, so you will get a sample size. So in this case, the sample size is n is each arm. So then 98. So I calculate 98. This here 99. So very close. Very close. Okay, that is and the formula for the continuous variable. For the binary outcome, the formula is similar. Similar. We also is actually same. So we also need to calculate the standard deviation and delta. That is risk difference. Okay, risk difference. Now the standard deviation is calculated as p times 1 minus p. So that p is average of p1 and p2. Okay, so this means, you know, for if we want to compare two proportions, we actually only need to know two parameters. One is the proportion or risk in arm B. Another is the proportion or risk in arm B. So we do not need to know the variation. Actually, the variation can be derived from two proportions. Okay, so the delta is P1 minus P2, and as standard deviation is square root of P times 1 minus P, where P is the average of two P values. Okay. Okay, we see, you know, we do subscale calculation. You know, actually, we do not need to know too many parameters. For continuous variable, we only need to know the clinical meaningful difference at the standard deviation. For binary outcome, we only need to know the two risks or two proportions by treatment arm. So where are these parameters from? Okay, so that is the issue. Okay, if I want to do sample size calculation, I need to do some literature review, literature search. So what can we learn? What can we find from empirical or existing studies? Okay, like a mean difference or two proportions. So we need to do systematic review or meta-analysis. Okay, or if you have to do exhaustive, you know, literature review, but you do not find data on the topical issue on these parameters, even for the different proportions or so we need to do a study or pilot study ourselves to get some you know, some information. Otherwise, you know, you cannot just, you know, manufacture the data, the parameter from your own brain. Okay. So that is assume parameter. The important is the, you know, when you do report, you know, the observed parameters should be provided in your report, so that you know, the reviewers, editors, the readers can check, you know, whether your sample size calculation was proper or not. Okay. And the last question I needed to ask is, you know, do you have a dropout? Okay. If this is a cross-section study without, you know, follow-up, so there be no dropout. Okay. If it is a case control study, it's retrospective, so there's no issue of dropout. But if it is a cohort study, if it is a randomized clinical trial, because, you know, these studies, they are all prospective, we need to follow up our study subject for a certain time period. Of course, you know, if we are going to follow up, some patients will be lost to follow up, will be lost. So we need to be realistic, to be fully aware of such you know, situations. So when we do sample size calculation, we need to inflate our sample size by assuming some proportion of, you know, dropouts. Okay, let's say if if we have, we sample size calculation means we need to have 200 subjects. But from empirical studies, we know about 20% of patients will be lost follow-up, will drop out. So how to do the sample size calculation? The calculation should be 200 divided by 1 minus 0.2. In other words, that 200 divided by 0.8. This will give you 250. 250. In other words, if you recruit 250 patients, you will have eventually you will have 200 patients have valid outcome, valid primary outcome. Okay. Sometimes people calculate simply by times 1.2 or the increase by 20%. So this is not a correct calculation because it's let's say if you have you have 240, you time 80%, you will get 195 or something patients. So much short than 200 patients required in the sample size calculation. Okay. And when we have the all parameters, we have the dropout rates, we can set up some possible scenarios. Okay, this is a table I produced for our collaborator for the the trial I just mentioned. Okay, that primary outcome was the amyloid level at 24 weeks. Okay. According to empirical studies, the difference could be 0.03, could be 0.05. That we have the range. Let's change from 0.03, 0.04 to 0.05. And also from empirical study that the standard deviation could be as low as 9.09, as high as 0.11. Okay, so we take a value 0.9, 0.10. 0.09, 0.10, 0.11. So now we combine and we give power 80% and 85. So we do all possible combination. We have total 18 possible scenarios. 18 possible scenarios. Now let's say if the alpha 0.5 and the difference 0.4, standard deviation is 0.1. So we need 100 patients. The power is 80.4. So this value is very close, to that, sample size we calculated earlier. Okay. So that is the, how to calculate what the parameters we need. When we work with clinicians, with collaborators, so actually we they phrase their questions in different ways. They have effect size on the side of and the power they want to sample size. That is one scenario. Another is they have the sample size. They have the effect size. They want to know how much the power could be. Or they have a sample size power, know how large effect could be detected. Okay. So the first one is given effect size and the power. The effect size that's changing from could be as low as 1 kilo reduction, could be as high as 7 kilo reduction. Okay. But with common standard deviation 10, right? 10 in the air. And so what with 80% of power is 80% of power. What is the sample size required? Okay, so if minus if it's a very small reduction difference, we need 3,142. But if we with largest difference, so we need only 68. Okay, so you see you can assume differently. you can assume differently. So sample size were different accordingly. Okay, that's one situation. Another is given the sample size power, given the sample size and the effect. So that this title is not correct. Given sample size and the effect is 2 kilo. So what is the power? Now we want to know the power. We have a sample size. Okay, so I want to do a study, but I want to see the power. Let's say I have a budget for 800 patients, but what would the power would be? Okay, you see, if you have 800 patients, you have the difference effect minus 2 kilo, so the power will be 80.6%. Okay, so another situation is given so this title is wrong. Given the sample size and the power, how large effect can be detected? Okay, so that is power 80%. So this is the sample size. So how much the effect can I detect? If you have only if you are going to the trial with 20 subjects, if you want to make it statistically significant at 80% of power, that difference needed to be minus 13.25. Okay. On the other hand, if you have 2,000 patients, if the mean difference, expect mean difference 1.25, so 8%, so that difference needed to be 1.25. Okay. Here we have some examples. This is a trial we did in Africa. So we want to see, insecticide treated bad legs for children from 0 to 4 years old. So we have three primary outcomes: PCV, occurrence of enlarged spleen. For the PCV is continuous variable, so that's we will compare means. So we need to load. We need the treatment effect to mean the difference in means. Or for the second one is occurrence enlarged spleen, that is risk difference. Okay, difference. Or we also have the time to event. This I'm going to below. I'm not going to talk about this more. Okay. Now let's continuous. Now we just simply introduce this into equation. We calculate. And if you do sample size calculation, and so this is the per arm. So you calculate 233.28. So you need to round up to 234. Not down, but up. Not 233. You raise up to 234. This is also a conservative approach. Okay. Or we can use a sample size formula. For the binary outcome, we can do the calculation in a similar fashion. Okay. This is a calculation according to formula, or this calculation according to the Excel-based software. Okay. Okay. Now one issue here. We know for the how about my time? How about my time? How many minutes do I have? Are you there?
He has sent a message in the chat box that he will be stepping out for 2 minutes.
2 minutes, okay. 2 minutes, okay, good. 2 minutes. I'll finish here.
No, he is. I think he's currently away for some time.
That's fine. That's fine. Okay. I have other things. I just ignore. I just jump out. I just do a quick summary. Quick summary. Sample size calculation is required for confirmative study. So what the situation we need to do sample size calculation? We have exploratory study, we have confirmatory study. Sample size, when we talk about sample size calculation, we refer to confirmative study. Sample size calculation we said should be based on the primary outcome. Okay. The parameters for sample size calculation should be justified based on empirical studies or pilot study. And when we do sample size calculation, we be better, more conservative, give larger than small sample size. Sample size calculation is not only a science, but also art. So it's a science. So we need to use a formula. Every parameter used should be justified. We say also it's art. So when we do sample size calculation, we have to be flexible to our collaborators. Do not just give one sample size. Just produce a sample size table, so that the clinicians, our collaborators, can have choice based on their budget, based on most likely scenario. Okay, that's my talk, and I'm happy to answer any questions. Thank you.
Great. Thanks, Donald. That's a lovely and succinct summary. Thanks very much. Dear fellows, any queries, questions, clarifications?
I just wanted to ask, in the summary, you pointed out that this sample size calculation is only needed for definitive trials. Does that mean for pilot studies, it's okay just to get out of it? Like, do we necessarily have to conduct power calculation?
Okay, I jump on this one. So for the exploratory study or pilot study, we usually do not do formal sample size calculation, simply because we do not have parameters to use in our sample size calculation. So this is a Lancet publication recently, and it is phase 2. It's a study, it's a trial. It says this, for exploratory analysis to generate a hypothesis, that no formal sample size calculation was carried out for this cohort. Sample size of 20 per arm was therefore chosen based on practical constraints. Okay, this is their original words. Okay, so this is so for exploratory study. For pilot study, there was a good publication in statistical method in medical research. And in this paper, it says, each arm, each group, we should have at least 30 subjects. Okay. And also, we do lots of secondary data analysis. For secondary data analysis, so we do not usually do sample size calculation. For example, we use the data from a cohort study done by someone else. They did the sample calculation originally. We just want to use it. So we do not need to do sample size calculation. Is that clear to you?
Yes, thank you.
Good.
And Donald, may I also request if, because all of these PhD scholars within each site are generally thinking of picking up feasibility studies or even pilot RCTs in some cases, and they usually struggle with sourcing a reference as to what's a bare minimum sample size, especially for psychosocial interventions related. So is there any resource that they can, quickly look into and feel a little more confident?
I'll send you this one. I'll send this reference to you. I send this
Right.
one. Read this one. It will provide, you can refer this one in your thesis or report or something. Low formal sample calculation. So this is, the main message from this paper.
Brilliant. That'd be great. That'd be great. Thanks, Dolo. Any other clarifications, dear fellows? We'll have Dolo, would you be happy to share a PDF of your presentation?
I'll send you my PPT and also this reference and
Thank
other
you.
documents to you. 4 or 5, or
Please.
3 or 5. I'll send the
That-
email to you so you can circulate to others. Okay.
Thank you very much, Dolo. That'd be great.
Mm.
So if there aren't any other questions, clarifications, or queries from the fellows, we can. Yes, Prasanta.
So, Professor, there's also one question. So if you are planning to do a definitive trial, for example, so how do we get the effect size power or maybe the mean differences, since do we refer to existing resources, literature to come up with the p-value, standard deviation and stuff?
Precisely. We do not need a p-value. We need just descriptive statistics. If it's a continuous outcome, we need to know 2 means and the standard deviation. For binary outcome, we just need to know what is the rates proportion in the control arm, what is the expected rates of proportion in the intervention active arm. So very simple. And then you just for as far as alpha is concerned, always set as 0.05. And the beta you can change if you have sufficient funding, increase power from 80 or 85, 90, 95. That's okay. But as far as alpha is concerned, you usually just set as 0.5%. Will be fine.
Great, thank you.
No more, yeah. Of course, we do not talk about class randomized trial. Class randomized trial is another matter. We need to know, that the intra-class correlation coefficient. That's different.
And just to add to that, in terms of the cluster randomized trials, I was yesterday just walking the fellows through the design, the conduct and the procedures of trying to minimize any biases. So I was referring to ICC, and I did tell them, because of this design effect, that people within groups will have similar outcomes. So that's where the cluster randomized control trials need to be larger in their sample in terms of the clusters. More the clusters, better the precision. Yes, more expensive the trial. But yes, so that's a design effect, and you need to account that for within your sample size calculations for cluster randomized control trials. So thank you very much for picking that up, Dolo.
You're welcome.
Right. Any other questions, dear fellows? Seems not. Thank you very much, Dolo. Thank you very much for your time. Lovely overview. Thank you very much. And stay well. Have a great rest of the day. We'll follow up over email and we'll request the materials from you. Thank you.
Thank you. Thank you for inviting me. I enjoyed your questions, and hope we can make it again. Thank you. Bye-bye.
Thanks.
Bye-bye.
Cheers. Bye. Right. Fellows, do you want to take a 7 minutes break?
Sure.
Good. So we will resume in 7 minutes. Get yourselves a cup of tea or yeah. So see you back. Bye.
Bye, see you.
Just raise your hands when you're once you're back, and then we will start. Let's wait for a couple of more minutes for perhaps Nabi and Pragya, and then we'll start. Just to double check, Nabi, are you back? So that we can then start. Great. Okay, lovely. Right, so just to sort of link this up from our yesterday's discussion, we did touch upon certain pitfalls or certain biases that one should keep in mind when conducting the study. You've picked up whatever study design you find appropriate, and then you start ensuring that you have enough internal validity and integrity of methodologies of conduct of your research to ensure that there is minimal biases. And what we need to now have a little bit of more focus in the next 25-30 minutes is to try and understand what are other types we touched upon some in yesterday's talk. We will touch upon some more. We'll try and define them, and then I would like to hear your thoughts, how you minimize these within your study designs or the things that you've been involved in. What were the things that you were doing to minimize these different sorts of biases? So let's start with the first, which is the most sort of common, is selection bias. So selection bias in very simple terms is that we either sometimes miss out an important portion of the people that we want to include, or we over-include one type of participants in our study. So there is some mismatch, some imbalance between the types of people that ought to have been in our study. And we did discuss yesterday that perhaps the best way the best way to select people for research is using the basis of this equal chance, yeah, so that everybody in the population or your target sample, which you want to investigate, has an equal chance of getting enrolled or not getting enrolled. So it's like the toss of a coin, yeah. Will Seham be part of the study or not? So it's an equal chance, 50-50% chance that Seham may or may not get recruited. So we yesterday discussed a little bit about what sorts of selection biases can come in, especially in trials, where you are allocating people to a particular treatment condition, and you don't want selection bias when you're especially in all study designs, but more so in your experiment where you're testing your intervention. So you want to minimize the selection bias. Usually it comes through various sources, and especially if the allocation is unconcealed, so people then tend to select one type of people as opposed to the others. That's known as post-randomization recruitment bias. I touched upon another important aspect, which is also selection bias. If your studies lose people to follow up, it's called attrition. Yesterday we saw Aisha Yousafzai's study had followed up 93% of people, so just a 7% of loss to follow up. That's a great response rate. 93% is a great response rate. And 7% is a small proportion which has been lost to follow up. And if there is, we also look at if this is equally distributed amongst both the arms, hoping that there is no differential loss in one more in one arm, the less in the other arm. And there are statistical ways to handle if there is an imbalance in loss to follow up. So loss to follow up also creates a type of a selection bias. Selection bias in terms of your interpretation of your results of the study. So I'll stop here, and I will perhaps ask you what are the kinds of strategies that you think are important to minimize selection bias within your samples, or perhaps even when you're doing feasibility studies within your sites. It's a small sample. How do you minimize selection bias within a very small sized study? So any suggestions, any approaches that you have been part of or have witnessed or plan to use to minimize selection bias? You can think about the kinds of studies that you've been involved in, previous studies. I know Nida's been involved in another trial in a hospital-based setting. So what were the strategies that they were using perhaps to minimize potential selection bias? Or Prasansa, you've been involved in a number of research projects in Nepal. So it'll be good to hear and sort of lean back on your existing experience.
So in my last research pertaining to maternal depression again, so what we did was we visited the health facilities and screened all the women, all pregnant and postnatal women visiting the health facilities. So after conducting universal screening, if anyone had a score above, had cutoff score, or more than that, we engage them in a qualitative study. So we believe that minimized our selection bias because we were screening everyone and not purposefully administering screening to a certain percent of women.
Great. And if I may ask, Prasansa, this was hospital-based?
It's a community-based health facility.
It's a right. So it's like a primary care facility or secondary care facility. Yeah.
Yes, and later we learned that not all women come to the health facility,
Yes.
and they do prefer the outreach clinics as well. So later we again added up, like, we revised our ethical application, and again we added up the community outreach clinics as well, and we visited there and screened all the women there as well.
Right. And if I may ask you to, are you clear why did you add those the other clinics?
Yes, because what happened was, when we limited to a health facility, we found like we only met mostly pregnant women, but when it comes to postnatal women, there were like very few in number. And when we inquired the health worker, why is that, and how can we contact the postnatal women, because the data shows in the register there are like a number of women, but when we come to the health facility we couldn't catch them. So they said, like, most of them they only come for immunization purpose, which is mainly availed at the community-based health community outreach clinics. So in order to capture them as well, we added that community outreach clinics.
Right. So your study, your approach was clearly missing out an important subgroup of your population,
Yeah.
the target population, or the interest, or the the interest population which you wanted to be evaluating or approaching. So that's, your study was clearly skewed to have more selection bias by having dropped out the postnatal women who are special interest group as well. Great. So that's a great example to minimize selection bias. Any others who can share some experience? That's a great learning how you address selection bias. Any suggestions or any comments from others?
Dr. Siam, I can share
Yes, go ahead.
one of my
Please,
experiences,
please.
but I think in that research we had the selection bias, is because we conducted a research. It was funded by U.S. State Department. It was about, we tried to see the internet use pattern of teenagers outside the the capital city, in the peripheral areas. So when we started the research, soon after we started the research, we went into lockdown. So we couldn't actually, and there was a time limitations. So we then, from the probability sampling, we went to snowball sampling. So we actually, go one, we find one, and from him or her, we went to another. And that's how we reached the minimum sample size we needed for the research. But I think we might have missed a portion. Like when we do snowball sampling, you actually get similar kind of people. So I think in that research, we had a kind of selection bias. But because of the time limitation, we couldn't do much, because it was all like online or through some local coordinators.
Understood. Great example. And I will just sort of and move on because we have to cover other biases. Please bear in mind and thinking, if you miss out a subsample and you have some potential selection bias, what will this mean? What will this mean in terms of your internal validity of your study? And what will it mean in the interpretation of your findings? For example, I know in Pakistan, as well as in literature, we find from other studies that women who are depressed have poor health-seeking behaviors. So if you recruit people with depression, or intend to recruit people with depression, women with depression from facilities, bear in mind that many of them with depression might not be visiting the health facilities. So to counter that, you go to community-based household recruitment strategy to ensure that there is no selection bias or an important group is not missed out. So keep in mind, keep thinking, what is this bias? What will it cause? will this limit my study in a way or the other, so that you can report it in the limitations part of the paper or report. Right. Another important set of biases is the observation bias and the observer bias. Observation bias is also known as.
I would just like to interrupt
Yeah, please go ahead.
and wanted to share the example from the ongoing study at hospital
Please go
setting.
ahead. Go ahead.
Yes, as you know, we are using the random methods when selecting subgroup from population. And we have two simultaneous studies ongoing at the hospital setting. One is for Happy Mother, Healthy Baby, and the other one is for sub-studies, blood sampling. So what we do is the initial stages, only the assessor knows the basic key characteristics of the potential participant and do the assessment. Then a randomizer who don't know the basic characteristics of the participant even, and her role is to simply narrate about the two groups and and this is how she can open the envelope. So this is the only strategy we are using to minimize the selection bias.
That's great. And Nida, if I may ask, this is a population of pregnant women or postnatal women?
This is the population of pregnant women.
Pregnant women, and it's a large tertiary care hospital-based setting, and where women enroll for their antenatal services and endeavor to have their deliveries done there as well. Right?
Yes.
Good. Yes. So you're just mentioning the concealment and how it's administered and how the people who are supposed to recruit, they're unaware. That's great. Those are strategies to minimize post-recruitment, post-randomization recruitment bias type of things. So that's a good strategy. Well done. Thanks for sharing that. So, Krishani, you wanted to say something?
Dr. Siham, I was thinking now when we are doing some research, we are putting some limitations like on because of the literacy level of people. Sometimes we put them under the exclusion criteria. So so that means that we are not giving equal chance for them to participate in the study. So what do you think about that? Is it like comes under this selection bias, or how to think about that?
Indeed, it is a selection bias. You're systematically and intentionally chucking out women or participants who are not literate, who are not educated. This will clearly have bearings on your finding, depending on what your research question is or what is your main objective of the study. But definitely, and this is a systematic, intentional way of chucking out people. It will clearly have bearings. So should not be done. I think especially education, Prashani, and this is a separate sort of since it is a social determinant of many public health conditions, be it depression, be it diabetes, non-communicable, etc. So it's one of the key social determinants. And if you take this out in public health studies, then you're minimizing the findings and the internal validity as well as external validity of your study and your finding. But great suggestion and great observation. So moving on to these two types of observer or observation related biases. So one is called Hawthorne effect. I'm sure you must have heard about this. So observation bias or Hawthorne effect happens when participants in a study are aware that they are being observed by scientists or by experimenters or by surveyors, and they either consciously or unconsciously alter the way that they react, behave, think. And many times it's also linked with some social desirability. So for example, if you were asking someone about their norms and they are now told that they're participating in a study, you give them the participants' information sheet, you narrate what the study objectives are and what is it that we want you to answer. And then you have certain questions. For example, do you endorse intimate partner violence? So many people, knowing that their responses will be recorded, what is your intuitive feeling that comes to your mind? What will they respond? If asked, do you endorse intimate partner violence? Would they respond the way that they actually think, or will they be more to be seen as more socially desirable and not endorse it? So that's what.
They
Go ahead, Nabi.
even many husbands who is involved in intimate partner violence, he'll say no, he doesn't endorse.
Exactly. Because now they know that they are under observation, so they will respond differently. So that's Hawthorne effect. That's a known observation bias. Literature also suggests that, so for example, this Hawthorne effect, if the study is progressive, it's continuing like a cohort study or even like a trial. So the Hawthorne effect generally gets minimized after about 2.5 to 3 months of being enrolled in the study. Then it becomes as per routine. Yeah. So there are many studies which use monitors, so audio monitors or CCTV. Initially, people, thinking that they're being observed, so they'll behave differently. But after a while, the presence of the CCTV or presence of an audio recorder on your person starts to fizzle out. They revert back to their original, their more original behaviors. So Hawthorne effect does tend to fizzle out. That's an important piece of information that you should have. Then the observer bias. So this may be the result of either the investigator or the experimenter's prior knowledge of the hypothesis, or which is under investigation, and or like blinding. Where blinding is rather an interviewer bias. So this is more I am part of the team. I am thinking that a particular intervention would have its effect, and now I think that all the participants are responding in a particular way, and I'm looking at the results. I'm trying to find the effect size. I may be partial to the p-values, the confidence intervals, the alternative hypothesis, because I am keen to see this this intervention being effective, and this usually is minimized when projects unmask the results. So, for example, trials, they're supposed to have a trial steering committee, which then does masked results. They show, they do not disclose the arms when they're reporting the results. They ask all the investigators to cast their opinions, that not knowing which group is doing better, is it the intervention or the control? And they then suggest that you put down your key interpretation if this is an intervention group which is showing better results. Why? If you think this is the control group that's showing better results, then why? So put down both your interpretation. Once they've seen the unmasked results, the trial steering committee, with the help of the statistician, unmasks the groups. And now, if the control group had better results, and the investigators now actually find out, okay, oops, it's the control group which was doing better compared to the intervention. They had already stated their interpretation. Now they can't change it. They can't, say something which is post hoc, which is post ad hoc interpretation of finding out, oh, no, this was the control group that did better and my trial is negative. So now they can't change their stand. So there are strategies to minimize this kind of observer bias.
Dr. Siams, quickly,
Sure, go ahead.
a question on that. So that means the people who are engaged with the analysis, they also need to be masked.
Yes, absolutely. Because in trials, Prasansa, generally it's just the trial statistician. Even the trial statistician at times, for being more stringent, needs to be blind. Yeah. So they work with blinded allocation status. So they will just know that this is group A, this is group B. What is group A and what is group B, they don't know. So it's just a way to ensure more internal validity, more better analysis. So interviewer bias, you already know if when an interviewer is either unmasked to the allocation status or is leading somebody into more leading questions, that you do endorse that people should be given this, right? Rather than what is your opinion about XYZ endorsement. So if somebody is systematically leading on or is unmasked or is unblinded to the allocation status, that's the interview bias. Recall bias is another sort of a bias which is to do with the respondent's memory and recall. There are definite certain events that people will always remember, which either are traumatic or are extremely comforting. So people will always remember earthquakes, will always remember adverse events to the quite a substantial detail. But short of that, they will always muddle up. They will always have difficulty in recalling. So many instruments use a shorter period of recall. So generally 1 month, 2 weeks, 1 week, yesterday. So the less the recall period, better and more reliable the information. So keep in mind, when you're using instruments, you should be wary of this sort of a recall bias. If you're asking something about last year versus last day, there will be issues around reliability. If this is reliably recalled or not. And that's how you minimize recall bias. Last but not the least, I thought that I'll slip this in. This is, I don't know if you're familiar with this, it's called the Rosenthal effect. And it's an interesting, this is to do with the, it's the experimenters or the investigators' expectations about the outcome of a given study. Yeah. And this operates at a level where the whole project, there is this goodwill, and the investigators are excited and they're looking forwards to, they train, their narrative from the top to the bottom, at the grassroots level. There is anticipation that, we will change the course of certain things. Yeah. So it's based in how it's narrated, how the project or the work is positioned from top to bottom and from ground to up. So there is this this goodwill, or so this in history has seen some evidence that it kind of biases the study results from the outset. So how to minimize this? Is usually to do all those kinds of things that we've just discussed. Keep the blinding in position. The experimenters, the investigators should have some restraint in sharing the hypothesis, especially within teams, so that they don't get influenced. Even if they're blinded, they shouldn't get influenced in a particular way that this will change the course of our outcomes. It should have an equipoise. We don't know if this will or will not. So that's the responsibility of the investigators or the experimenters. So I thought that I'll just list these out, these potential biases and how you minimize it. So each has its importance, but keep in mind blinding, which is interviewer bias, recall bias, that's to do with the reliability, and selection bias are most foremostly important biases to watch out. Any questions, clarifications, queries before we take on the issue of measurements? Right. I think this, in terms of designing your individual studies, whatever design you use, however you minimize biases in the conduct of your study, I think an important area of consideration is how are you measuring not only your independent variables, as well as your outcome or dependent variable, or your dependent or your outcome, or your what's your outcome measure, or what is the outcome construct that you are trying to capture. So I think this is an important area, and it should be looked into with equal amount of rigor and equal amount of understanding and equal amount of vigilance. So I thought that I would talk about the issue of measurements. What are the types of measurements that we use? Different constructs have different ways of measuring them. Your hypotheses, your objectives are all based on variables. And how do you collect that variable? How do you collect that data around that? It's important. So what are the different types? What are the approaches? And I thought that how do you move from, say, for example, I know in Pakistan, all the respondents, when we ask questions, they will either respond in one or the other dialect of Urdu. So, or they will speak in Punjabi, or they will speak in Sinhalese, they'll speak in Nepalese, they'll speak in Bengali. So all these instruments which are English, how do you take them to your study settings? Will that require any translation? What are the issues around translating? What are the issues around anything which is not culturally appropriate? So how do you take those tools which are based in English, were developed in one context, and how do you use them in the other context? So what's the issues around adaptation and translation? Are there any methods? Because if so much of emphasis is based on measurements, then you need to have some methods to ensure that these tools are not only reliable, but are also valid. So what are the issues around validity and reliability? So I thought that we'll try and cover this aspect as well. So let's start with the one, and since it's more, I come from a global mental health perspective, but I will be interested to hear from, because it's a multidisciplinary set of fellows. I would like to hear if there are other sorts of instruments, and please bear in mind we're talking about quantitative measurements or measures. So please do pitch in if there are other sorts of instruments. So the broad category that the broad classification that I am using is that there are some tools which are classified as screening instruments. So they screen a condition, because I'm looking at evaluating complex interventions for conditions like maternal depression, or conditions like diabetes, or conditions, so there will be some instruments that will give me an idea. They will screen, and they will give me some cutoffs. That's generally the types of screening instruments that we use for depression. There is one called the Patient Health Questionnaire. It has 9 items. It's usually mapped on a particular international standardized classification of depression. Similarly, there is another tool which screens for anxiety. If a person has probable anxiety disorder, so it's also based on an international standardized classification of anxiety disorders. So these screening instruments, they will just barely tell the investigator that there is potential presence of a particular disorder or condition that you're looking for. It's many times these studies, I think Prasansa was saying that people in one of the studies that she did, so they were screening, and people who were scoring particularly at a particular level, they were being asked to take part in the, sorry, clearing my throat. So many studies also do is that a particular cutoff, if a person is screening at a particular cutoff, then they are administered what we call diagnostic interview or diagnostic instrument, so that you diagnose people and then recruit. So many studies will use this screening step, the screening phase as step 1. And the studies which use these sort of 2 steps, first identify people who are scoring in a particular way on screening instruments, then apply the more diagnostic approach. So these are two-stage designed studies, and usually these are the types of designs that are used in validation or validity studies. We'll come to that. But please keep in mind that these screening instruments will have some limitations. They will probably just indicate towards the probability of having a condition that you're interested in, not a diagnosis of that condition. So because we are relying on some cutoffs, generally these will give you a continuous score. So a continuous variable. By the way, you all are familiar with the categorical and continuous variables. I'm sure you would be. You all are familiar with continuous measures and categorical measures, right? Just raise your hand.
I think I am, but yeah. If you yeah,
sure, I can. Sure, I can, for the benefit of revising and refreshing one's memory. So data is the information that you gather. Now, this information can be in two basic types. One type of data is a numerical value. So for example, if somebody asks me, Seham, what is your age? So I will tell them that I am 50 years old. So there's a number. And then the age as piece of data or as piece of information can vary on a scale. So I can be 0 years old and I can be 85 years old. So it goes from 0 to what's the life expectancy of a particular country. So you can have 0 to 100, a range of values. So that is number-based, numeric-based piece of information or data. This particular type of variable, age in years, becomes a continuous variable. It will, so for example, my blood pressure will be on a scale. So 120 over 80, it can range from that value to, so it will work on a kind of a scale or a ruler. So it's a continuous variable, but it's all based in numeric numbers. And whenever you talk about numbers, when you do stats, so what you do is these will generate means. The means will also give you standard deviation. Many a times you want to describe the distribution of, so people on this call, somebody's 50 years old, somebody's 20 years old, somebody's 30 years old. Now I can describe this variable, which is age, which is a continuous variable. I can describe it in a number of ways. I can say, I can pick up the arithmetical mean. So I will add all of the ages and divide by the number of people. I can also use a statistical mean and provide you with a standard deviation. I can also do, if there is a wide sort of range of different ages. So if we had a person who was 2 years old and a person who's 50 years old, so there is a huge variety. So many a times means will not make me understand what the distribution is. So I will use median. So median value, so these are all based on numbers. So that's what continuous variable is. or a measure which gives you a continuous score is all based on numbers. The screening instruments will generally generate a score, which is a number, which can vary from 0. For example, if I use the example of PHQ-9, so I can score 0 as in no depression, or a maximum score of 27. So the scores will run on a scale 0 to 27. So this is a continuous measure. This is a continuous variable. Now coming to categorical variable. So, for example, if I were to ask you, what is the number of people who are men and who are women on this call? So gender is a category. So you will have XYZ proportion or number, and out of that you will create a proportion. So that's your categories. So people, so gender is a categorical variable. So you, for example, how many people on this call, you can create categories. So elderly and young based on an age. Yeah? So you can similarly use this same tool, which is giving me 0 to 27. If people score say 0 to 4, I will say that this is no depression category. If people score 5 to 9 on PHQ-9, this will be mild depression. So I can divide using different cutoffs on my scale, people who are not depressed, mildly depressed, moderately severe depressed, or severely depressed. So categories is another form of informing or getting or using data. And usually it's expressed in proportions. So that's your category: people who are depressed, not depressed, poor, not poor, literate, not literate, illiterate, first-time mothers, not first-time mothers. So these are all categorical data expressed in proportions, frequencies, etc. And so these are the two basic forms of variables that can be expressed: categorical or continuous variable. Hope that helps clarify. Right. So moving onwards, these screening instruments will just let you know that there is a probability of a particular condition. The lower, depending on the type of the instrument and type of the scoring, many a times 0 score means 0 condition. Maximum score means more likelihood of that particular condition. So if you're taking if you're using the example of depression, lower the scores, no depression; higher the scores, more depression. So these are usually the higher cutoffs are used for more ensuring that more likelihood of that condition to be present. Screening instruments are easy to use. When I say easy to use, means that you can train people. These are fixed responses. So you have to read out you can't change each individual item. It is as asked it is. It forces the respondent to respond in a particular way. So it's easy to use, it's easy to train people on, it's less expensive as well. Whereas when you move to a more diagnostic approach and more interview-based approach, it starts to get not only expensive, time-taking, but it also improves the rigor of the of finding the condition that you're interested in. And I use this example again from global mental health perspective. We're interested, if you're interested in diagnosing somebody with depression, so there are interviews, semi-structured diagnostic interviews where you ask respondents in a semi-structured approach individual items about depression. These are generally based on some international standardized classifications. More European-based is International Classification of Disease, ICD. More American-based classification is DSM. Diagnostic and Statistical Manual for Mental Health Disorders. Now, this set of classification has recently done a revision. So generally, DSM-5 is in use now. So these are clinical interviews. So generally, clinicians can do this, but for depression, for perinatal depression, one of the diagnostic interviews within this particular manual that I am showing you, called SCID. SCID just means it's a structured clinical interview for DSM-4, now DSM-5 disorders. But you can use diagnostic interview module for perinatal depression that has been cross-culturally adapted and has been used in many low middle income country settings. So diagnostic interviews require lots of training. It can be used through non-specialists. We've done that, but it just requires a bit of more training. Obviously, this is a standardized approach. This gives you a more robust outcome measure that you're showing that you have reduced actual depression rather than probable depression, which screening instruments generally tell. So any confusion in terms of what is a screening tool or what is a diagnostic tool? Or are there any additions to these sorts of tools or approaches? Great. So let's move on. So now is the question about how do you ensure or how do you do cultural adaptation and translation of instruments or diagnostic interviews for that matter. So bear in mind that that cultural adaptation, not only for your intervention that you're doing, you require the same rigor and same approach of adapting certain instruments and translating them. So there is lots of literature, lots of approaches available, which have been over decades being refined. So by cultural adaptation, what we mean is that an instrument is more relevant to a particular context. When it becomes more relevant, the result is that it will be more reliable. And I will give you an example of an instrument which one of my students used I had not used it, so I was supervising a public health master's student in Pakistan, and the topic was to understand, because we were at that time having lots of terrorism, and our law enforcement agency, the police, would have these fences, these barricades put up on individual checkpoints, and would be standing there the whole day, screening cars and asking for, checking for that, for people as a security measure. So he used an instrument to look at the organizational level of turnout. And it was a Swedish instrument which was developed in Sweden, not in Switzerland. And one of the items on that instrument was record keeping. And in Switzerland, since it was a high income country setting and far more developed, so the item read that the number of hours that you spend in typing your police report into the system's computer. So in Pakistan, police has not transitioned to using computers. So they still have these registers, huge registers, which they handwrite into. So the cultural adaptation meant that both sets of polices here in Pakistan as well as in Switzerland do record, do report, do enter their findings into a report. But the procedure that they use is, one is register, the other is computer-based. So the adaptation was changing the computer, word of computer, into more register. So that's more culturally relevant. Otherwise, had that been used in our settings, all of the police people would have said, no, we don't use computers, so we do not enter reports in the computer. So it would have read that there is no computer use, which is absolutely not valid, which is not absolutely reliable. So that's the kind of cultural adaptation which all instruments should feature. So this is an important step. And I'm sure in your experience, I would like to hear from you all the kinds of studies that you've already been involved. Have you encountered this issue of adapting an instrument to your setting? I'd love to hear from all of you, from your examples.
So when we were translating and validating the post-traumatic growth inventory in our Nepali culture, so we struggled with actually like few of the concepts. So the concept of universe, the concept of spirituality in Nepal. So although we translated to the nearest, to the closest word, when we actually use that in the community, it was not understood properly. So when we when we talked about spirituality, the concept of spirituality is more often linked with religion in Nepal. So it was kind of difficult to make them understand. So this was just like we were just checking whether the translated version was understood by the community or not. So that was our finding. We didn't take any further step on that to make it more contextual, but then that was the issue that we had faced.
Yes, excellent example. It's to do with this difficult construct of spirituality, and every culture will have its own ways of articulating it. So any other examples from other sites? Shani, Nabi, Nida, if you can share any particular example.
Where I tried to find a Bangla version of PHQ-9 online, and I got one. It's mainly translated and validated. It's by a group from Kolkata. You know, Kolkata, it's on the Indian part. It's also used Bangla, but it's on the Indian side. But what I found, it's more of a literal translation, and it's a very, you know, in sometimes it doesn't really gives the sense of the sentence. So I actually translated one, and I applied to one of the maid who temporarily comes to our house and lives in a slum. So, and then I put a score, and when I actually discussed with my local supervisor, he said, did you, the maid responded to my questions, but my supervisor, Professor Omar, said, did you ask what she actually means by the word? Does he get the same meaning by the word that you are meaning? So before you translate, you actually, you know, ask her, like, what does he mean by this word? And then, you know, put down the word. So we thought, like, you know, the one that's translated by the Kolkata team is not actually a proper one. It's more of like a very literal translation. So there should be another one that should be validated. That's it. Thank you.
Excellent. No, excellent example, Nabi. And what you're actually referring to is a couple of concepts. So there is this conceptual equivalence, right? Which is probably not captured. Yeah, there is some level of semantic issues. So the translations that they're difficult, and they don't make sense. Yeah. So these are all the kinds of things which people have documented on in terms of ensuring when you're adapting, when you're translating, there's not only conceptual equivalence, there's item equivalence, there's semantic, operational, measurement, and functional. Functional is later when perhaps that's something which comes from other studies and other evaluations and other sets. So you should all be concerned with conceptual items, semantic, as well as operational equivalence before you take up your individual studies. And we can we can talk about all of these, what they mean, how to approach them in the upcoming slides. Shani, any examples from your end, or Nida, if you would like to share? Otherwise, we can move on.
Actually, I don't have the first-hand experience of translating instruments. By the way, I remember that I went through Professor Atula Sumatipala's article on how to do this, the issues in translation and back translation in translating PHQ-9 into Sri Lankan version, and also the short explanatory model, that questionnaire. So I just remembered those. Yeah, I think this is also applicable in our setting, but I can't give you the same like.
No, but yeah. No, you're absolutely right. And what you were doing using Atula, you were engaging with discussions with specialists. Yeah. What Nabi was being asked by Professor Umar or Shamoon was also conceptual equivalence. Ask the person, what did she or he understand by what you were asking? So, you know, you're discussing with the target population as well. So these are quite important steps that all of you are referring to, and we'll see that how this is helped in adaptation process as well as in the translation process. Nida, anything from your side? Any experience or any?
Dr. Saham, as such, there is no recent example or specific example in my mind, as we didn't translate any instrument recently. But yes, I have been involved in many processes for translating the tools and cultural adaptation. So I hope you will also talk about the piloting of the instrument after translation and adaptation, because this process, when cognitively interviewing from the community-based people, you get so many responses, what the late terminologies they actually understood to respond in a better way. So there comes the another process when you talk about with the expert panel and revise the translation and adaptation. So that was in my mind.
No, excellent. And you're referring to important procedures. Nida, you're referring to important procedures to ensure that there is semantic equivalence, and it's a process. It's a kind of a cyclical process that you use to ensure that there will be utmost validity of your instrument. If you ensure that, rest assured the reliability will follow. And I'll come to that. But thank you for that input.
Can I add one thing here?
Please.
This is not the screening tool or item, but it is about Likert scale. Because here, when we saw ladder, from people, some people won't understand from 0 to 10 or 0 to 5. So, so we used Doko. Do you know what Doko means? Doko means a basket where, yeah, where basket where we put grass, cutted grass. So for that we use like the empty basket, and then full of basket, and a basket with half full.
Right.
So we use this for a Likert scale.
Excellent. I think that's a very good example of operationalizing the procedure in a way that you achieve some important contextual understanding. So letters may not be understood. So using that, excellent. We recently used, we didn't use a Doko, but we used a glass. The more filled a glass was, the more likelihood. So using kind of an analog, a visual analog. So half empty meant, less chances, more filled. So we've used that approach as well. But you're absolutely right. And that's more the procedure which you make it easy for people to understand. That's also a very good example. And that probably hinges on trying to achieve some operational equivalence. So Likert scales may not be operationally understood, so using some visual analogs type of thing. So it's to do with the format of how you deliver or how you administer the instrument. Great examples. Right. So let's look at this adaptation process. You've all mentioned in some way or the other, you're all very much familiar with the core concepts. Since adaptation is a method, so in literature there are quite a few sort of approaches, and I myself in my practice I favor one to the others depending on the type of instrument that I am using. So there are approaches by WHO. There are approaches by people like Bilal. So Dr. Ravan and Dr. Khan. One's based in London School, the other's based in Karachi. So and there is one Swedish, I think Swedish or Swiss approach of adapting instruments. Then there is another, so there are a number of approaches where you can use methodologically to ensure that you've achieved equivalence of many different types, which I was showing. So conceptual equivalence, item equivalence, semantic, they all mean something or the other. So the process by which you take, so there are not many, so there are just 2 or 3 with overlapping similarities. But the adaptation process itself, uses basically either a statistical approach, so very quantitative procedures like perhaps Nida was mentioning that once you're done with that, you go and pilot it. You do some, you look at what the measurement's showing. So you do some statistical. You look at that data, the distribution, etc. You look at what the items mean, etc. And then there is more operative way. There is a more qualitative approach which is used in adapting the instrument, right? And many of you voiced that already. Nabi was interested in understanding what the person who he administered the instrument to understood. Same was the case with Prasansa's example about spirituality. Or for example, I was mentioning another type of equivalence of this police report entry mechanism. Or for that matter, I remember a Ugandan study, similar to Pakistan. They don't have a Ugandan word for depression. In Urdu, there is no single word for depression. So many words are described in Urdu to, understand what you mean by depression. So, for example, in Uganda, if you translate the phrase which they use for narrating that they probably are depressed, so it sounds something like this: that my heart has stopped working. I don't have my heart anymore. So in Ugandan language, that's the phrase that they use. So clearly, you clearly, immediately, qualitatively understand that something translated from Ugandan language is, harping on the heart. And heart has nothing to do with depression. So heart is a very physical organ. Depression is all very psychological with some biological symptoms. So how do you ensure that there is construct equivalence? So this is the operative, more qualitative approach of trying to ensure a number of types of equivalences across the instrument. So I use this this table one of the studies which has referred to this, and it's almost similar to the types of equivalences listed here. So conceptual equivalence is, what it means is that the construct, the idea, say spirituality, the construct depression, say the construct social support, yeah. So the conceptual equivalence just means that in Urdu, in Nepalese, in Sinhalese, or whatever the language, Bengali, the concept of depression or anxiety or social support, yeah, is translated or is moved, is captured in that language. So you're not picking up something else as opposed to social support. So that's what the conceptual equivalence means. The content equivalence means that you ensure that the item relevance is there. So now the construct has to be described in So there will be multiple items which will talk about social support, for example, or for that matter, depression. Depression includes trouble in sleeping, trouble in eating, trouble with concentration, trouble with loss of interest in pleasurable activities. There is another item in which you feel low in mood, sad. So all of these items will try and capture that larger construct, the larger concept. You need to ensure that individual items also have equivalence, also mean the same thing. Semantic equivalence is also the meaning, the language. At times, you need to reduce the language to a person who is perhaps just 3 years of education or even illiterate. So you need to ensure that when you're moving from semantic equivalence is there in a way that it's easily understood. Technical equivalence is another aspect of adaptation that requires your attention, as well as criterion equivalence. We'll come to that. But what's the face validity? Let's not use those terms right now. But on the face, there are processes, operative processes. You use 2 independent sets of people to first translate it. There is this methodology of back translating. Now WHO, as well as those Swiss people, the methodology recently, they just say that you just forward translate, you don't back translate. There's no need to do that. You involve your target population. You also involve your clinicians or experts. They will guide through their experience to fine-tune all these equivalences, be it the words, be it the procedural, like Pragya perhaps mentioned about the DOCO, or us using the glass. So people will comment, this is not understood. So whatever procedure you take, or forward translating, backward translating, and adaptation, you will have to involve the experts and the user groups. Yeah. When I say user groups, they are participants, and one way or the other, you all understand the process. It's just that sequence that you need to take. Last but not the least, you then pilot it, like Nida was saying. So on a handful of people, you pilot it, you see what the trends are, you see if any of the items is misbehaving, is not working well. So after you've done the due diligence of not only translating, going back to the experts, going back to the specialists, going back to the field, going back to the lay people, ensuring that there is all types of equivalences ensured, and then you pilot it. See if it flows well, people understand, people don't come back and ask you questions, because that you've already dealt with through cognitive walkthroughs or qualitative cognitive interviews. So that's the main sort of idea of adaptation, cultural adaptation, as well as translating back or forwards through independent people. But at the core, you need to ensure that whatever construct you are approaching to measure in a particular language, it should have all sorts of equivalences, be it semantic, be it item, be it content, be it operational, be it conceptual. And there are a number of methodologies that you can approach and use. So I hope we are all clear on this very important aspect, because this directly is linked to the instrument's reliability as well as validity. Any questions, any clarifications that you require at this point in time?
So just thinking out loud,
Yeah.
because some of these tools are self-administered tools, for example, the APTS and stuff. But in our case, in Nepal, when we use that in the community, not everyone can read the screening tool and, like, self-administer the tool. So in that case, the health worker has to administer it. So does that make any difference? Or, like, do we have to take approval from the developer that in our case, we will be administering it through the health worker? So how does it work?
I think that's an important consideration, Prasansa, and I think within our types of settings, all of these self-administered questionnaires, are then administered by an assessor, and this is an important transition. So more so, the translations and the adaptations should be spot on. And then it's a training need and a supervision need of the set of assessors who are administering this, so that they don't veer off the statement. Whatever that statement item is, has to be read out aloud as many times as the respondent needs to, for her or him to ensure that they have understood. Then your assessor cannot move around and narrate it in her or his own language, or in her or his own way, that this item is not being understood by the person, so I will rephrase it. You can't do that. And that's where the training and supervision needs arises. But all of our studies very rarely employ, in this low literate populations, rarely use self-administered questionnaires. But there are ways to ensure that they're still reliable, they're still valid. Any other points or suggestions or comments? Right. So let's move on to these two important constructs, if I may say, reliability and validity. So reliability is just refers to how consistently a method or a tool, we are talking about a tool now, or an instrument, measures something consistently. The emphasis is consistently. So if the same result can be reproduced, achieved, whenever I use that instrument, it always consistently, under the same conditions and circumstances, gives back the same result or the same finding. So that's what it is meant by consistent. So reproducible, repeatable. So that's what reliability means. Can you give an example of something which is reliable, so that I understand that you're familiar with the concept of reliability, and especially reliability of an instrument? Any examples that you can give?
What came into my mind, if I administer PHQ-91 to a person and I found a kind of mild depression, so and within a short period of time, if the same result came out, because it's the same circumstances, so it'll be like reliable, the translation.
Excellent. That's an excellent example, Navi. And what you've done is you tested, you used the instrument, and after some time can vary from 1 hour to 7 days or whatever. Yeah. But the same person was administering and the same person was answering. So you've done test, retest. So at both time points, you get the same result that is consistent. So this, what you've done is you've done test, retest reliability. So great example. Excellent. Any other examples that can illustrate that you understand the concept of reliability? So if I were to ask you, now here's a question. Yeah, I know that you all have, you all converse in English, and many of you have done your English international test. So here's a question. If I were to ask you, yeah, say if I ask this question from, if I pose this question to Krishani, Krishani, can you please tell me the spelling of cat? So what would be your response?
Cat.
Yeah, cat. Can you spell it? Can you spell it for me? Now this is a basic question.
Yes,
Yeah.
cat.
CAT cat, right? Now I know CAT cat. Yeah. So now if I ask this question repeatedly over and over again, I will get the same response from Krishani. Yeah. So this is a reliable question that I am posing. Knowing that somebody is educated, knowing that they converse in English, so they will be familiar with the alphabet. So I am posing a question, and this question seems to be reliable. Whenever I ask it, how many number of times I ask it, even if I ask it later down the line, later down years, probably she will still remember how to spell cat. Yeah. So that's an example of reliability. Right. So then what is validity? So validity just refers to how accurately, now it's not about consistency. Now it's about how accurately a method measures what you're intending to measure. Yeah. So that's the catch. It's the accuracy, it's the zeroing in on what you intend to capture. So if any of your tool or any of your project is measuring something in high degree of validity, yeah. So rest assured, it is not only reflecting the real parameters in the population, yeah, but it's also ensuring that there is a fairly high degree of reliability. So for example, if a tool like PHQ-9, we know it's based on a standardized classification criteria, and I'm talking about the English version at the moment, right? If you use the cutoffs of 10 or above, a maximum score is 27, and I'm saying I will use a score of 10 and above, then you are not only it's a reliable instrument, but you're also ensuring that this cutoff that I've used is a valid cutoff, because anything above this is most likely depression. And actually, this is representative. If people are scoring way above 10, majority of them are scoring way above more than 10, then it is truly representative of people in that population are most likely depressed. So validity is to assess as accurately as possible what you intend assessing. Can you give me some examples out of your personal experience which can illustrate that you understand what validity of an instrument means?
So just wanted to give an example of the community informant detection tool that we had initially developed. So we came up with the tool, but we didn't know whether the lady health workers, similar to, the female volunteers, would be able to use it, and whether the tool actually identifies people with probable depression. So they first administered the community informant detection tool that we had developed, and there the same person was also assessed by the community counselor as using the PHQ-9. So that's so that's how we validated the tool. So comparing the results from both the assessors at the community and the counselor level.
Excellent example. Can anybody add to that, share experience, which illustrates?
Can an instrument can produce a similar results? It's reliable, but it may fail to diagnose accurately. So it may have reliability, but may lack validity.
Yeah, you're absolutely right.
All right, yeah. So for if I administer PHQ-9, referring to my previous example, but it finds someone not depressed, but she's actually depressed. So it's having similar results in both occasions, but it fails to screen her properly, so it lacks validity.
Exactly. And what you're referring to, Nabi, is, which is next part of my discussion, that you're missing out. So there is a false negative. Actually, the woman that you saw was actually depressed, but your instrument missed her. So you picked up something else, or you picked up entirely, you didn't even pick it up. So you intended to see if there was depression or not, but your tool failed you. So the tool is not valid. Whatever it is picking up can be picked up repeatedly. That's to do with reliability. It's consistently either picking up whatever, but it's not picking up depression. So validity is just that what you intend picking up, the tool is actually picking that up. So for example, now, building on the example that I used, spelling of cat, yeah. Now my intention is to ask that if Krishani or Prasansa or Nida does know the spelling of cat, yeah. And now I'm posing this question, that can you tell me what is 2 plus 2? Your answer will be what? 4. But I intended to inquire that, do you know the spelling of cat? So then asking what is 2 plus 2 is not a valid question, because this is not capturing what I intend. I intend knowing that you all know the spelling of cat or not, but instead I'm asking what is 2 plus 2. This is not a valid question. So I hope the issue of validity is so important when you're adapting, translating. So this has to do with the construct equivalence. Are you capturing social support or not? Are you capturing and measuring depression or not? Yeah, are you capturing and measuring spirituality or not? Is your tool picking up spirituality as intended or not? Is that valid or not, right? So that's the difference between validity and reliability. There are a number of types of reliability, consistency checks that you can provide and do. So Nabi talked about this test retest. There is one thing which is known as inter-rater. Now, inter-rater means that I am administering PHQ-9, and so is NIDA. When administered on the same individual, NIDA also gets the same answer. I also get the same answer. So it's inter-rater reliability, which should be in a particular agreement. It shouldn't be like that if I am referring, if I am labeling somebody as severely depressed, so NIDA is labeling that person as not depressed. So our inter-rater reliability is really poor, right? So that's one form of reliability. Then there is another form of reliability, which is called internal consistency. So when you see all of these instruments or all of these tools, you will find that there are a number of items which will be capturing the same construct. So for depression, there is sleep, low mood, etc. So there are 9 items in PHQ-9, and they are all linked with each other in one way or the other. So is there internal consistency within these items? So people who will score high should also be picking up these the items. Yeah. So they load on each other. So that's known as internal consistency. Cronbach alpha is one of the measures that you use. Higher the Cronbach alpha, the better the internal consistency. Inter-rater reliability is, we use a statistical term which is known as kappa, or you can express this in a percentage as well. So anything above 80 or I think 75% agreement is considered as good inter-rater reliability, good agreement. And you should aim for, if there are people in the field who are assessing, it's a larger team, so you will have to train them and ensure there's quality of there's inter-rater reliability. Coming to validities, so there are a number of types of validities, but the more important ones, well, all of them are important. These are the 3 kinds of validities for instruments which is looked into. So construct validity. So it's the what we were just referring to. Yeah. So adherence of a measure to the existing theory or knowledge. The construct itself, depression, support, spirituality. Content validity just refers to the extent to which the measurement covers all aspects of the concept. Yeah. Which is related to the individual items, which we checked that they're internally consistent. But are they picking up the individual items properly or not? Criterion validity is the extent to which the result of the measure corresponds to the to other valid measures. So criterion validity is the comparator, the gold standard. So for example, in depression, our gold standard will be a diagnostic interview, right? So criterion validity of PHQ-9 will just mean that if I use PHQ-9 on 10 people, and I show that 8 of them are depressed. If I use a diagnostic interview on the same 10 people, yeah, is this showing 8 or less or more? So I don't know if you've heard of area under the curve. So it's comparing your instrument, which you've adapted and translated, directly a comparison with the gold standard. So the area under the graph or a ROC curve, receiver operator curve is created where you see agreement. So higher the criterion validity just means that it is comparable to a gold standard, right? So these are the kinds of reliabilities and validities that we generally try and ensure when you're adapting and translating your tools. No matter what procedures you use forward translation, backward translation, ensure through qualitative approaches, by doing some cognitive interviews, by reflections with the experts, with the participants, ensure all types of construct, content, equivalence, semantic equivalence is there. Use easy language when you're thinking of translating your instruments, and then pilot them, of course, whenever possible, because this measurement is an issue where all reviewers, all types of academics keep asking you if this was validly, was this a valid instrument? Were you actually looking at depression in Bengali or not? The best approach is to then try and do a validation study. And validation study is very very useful to set aside this debate. Is this tool valid or not? Is this tool reliable or not? Yeah. So you undertake a small study in which you use the translated version, and then you also on the same population use a diagnostic or a gold standard, and then you compare and you then publish. So that sets aside that it's a valid tool that you've used. So in Pakistan, PHQ-9 has been validated for perinatal population for a number of studies. Generalized anxiety disorder has not been validated, I think. But there are other instruments that have been validated. I know in Nepal and Sri Lanka, I think there is a Sinhalese version of PHQ-9 that's been validated. Nabi was saying about Bengali version being validated in Kolkata, but it has some minor sort of face validity or the content validity questionable. So some items may need a little bit of fine tuning. So I'll stop here. If you have any queries, questions, things to sort of clarify, I'd be happy to answer.
Dr. Siam, does data triangulation also comes under reliability types?
Data triangulation. Can you elaborate that point?
So, in order to check whether the respondent's response is actually correct, we tend to ask, for example, some other people apart from the respondent to check if the response is actually.
I think I understand. Okay, I understand. I think, yes, what you're trying to do is to corroborate from other people that the response that has been given is, completely understood, and the response that has been given, can I take it? Is this reliable? So you're just trying to ensure that whatever feedback that person has given is also corroborated or is also sort of endorsed by another person. So I think yes, absolutely. You're just trying to ensure either semantic or content or construct equivalence, no matter what the source is. I think that's very valid, and it is something that is usually done in many studies. Right. Any other question? Right. So we are actually 15 minutes into our break. So let's meet in exactly 45 minutes. And then Dr. Ahmed Waqas will pick up on how to approach analysis. Although we're running behind schedule, so please keep thinking about the instruments and measurements that you will be using. So let's break for 45 minutes. See you all in 45 minutes. Yeah.
Sure.
Sure.
Great.
Can we pause the recording and then maybe?
We can. Nida, can we do that? I think we can pause the recording.
Yes, Dr. Sian, we can.
Right. So let me pause it. I think I